morning and very warm welcome to you all. It's my privilege to introduce Dr. Arvind Kumar Maria. He is the first Indian to win the Ophthalmological Star Award in Amsterdam, ESCRS 2021. AIBS International Hero Award for the year 2021, 2022, 2023 and 2024. First to receive AIBS Senior Academic Achiever Award 2021. Many Best Free Paper Award and Colonel Rangachari finalist in AIOC. Heading many projects based on all AI on deer and diabetic retinopathy and glaucoma. 600 international and national presentations. 600 international and national presentations. 100 international and national presentations also. Associate Professor of UK JAWS Section, Editor IJO, and Editorial Board Member of EC Ophthalmology, WJCC, and so many DAWS, Times, JAWS, etc. Conference, many Oration Awards, Best Video Award and IJO Honor Award by AIOS. International Faculty at SICS, WOC, ICO, ESCRS. Social Enterprises in the year 2023, Award by Ophthalmological Practice Development. And top 7 AIOS Guru Shangram National Resource Faculty. He is the Additional Professor and Head Cataract, Glaucoma, Refractive Squint, Pediatric Ophthalmology and Medical Retina Sciences, Medical Services, All India Institute of Medical Sciences, Hyderabad. So I welcome Dr. Arvind Kumar Maurya, and now over to you, sir.
8 बचे हुए हैं and all the DNPs. Nursing officer. आईओएल नहीं आया अभी तक. हाँ, डीएनबी स्टूडेंट से बुलाइए मैम. जी रिटायरमेंट अभी तो उनका ज्वाइनिंग का एज है. जी जी No, I will ask everything. You can ask anything. Okay, okay. Shall we start now? दो भी नहीं लाए. दो हम आपको पहले दिए थे ना. अच्छा. So, good morning, my dear friends, and it's an honor and privilege, and thanks JAWS Ophthalmic Society, Dr. Bharti Kashyap, Dr. R.C. Kashyap, and all of you. It's an honor to be here. So, we are associated with 12 patented innovations in ophthalmology, ranging with the microscope, some changes in the microscope, IOLs, the smallest drainage device for glaucoma, the choppers. So there are almost 12 innovations. So in today's live surgery, I try to use 4 of the innovation. Number 1 is the Mohan Rajan chopper for the hard cataract, doing the vertical chop, and then using the terminator chopper, that is by the Dr. Rajendra Prasad, and then I use a sewing needle microcapsulotom to prevent Argentinian flag sign. So it makes a small regular hole, so it prevents the extension of the this rhexis. And the number 4, the star innovator is of course the autofocus pro IOL. That is the world's first no negative dysphotopsia IOL. It is a ringless IOL. There are no refractive or diffractive zones in that, and there is no halos, there is no glare, and it has an excellent stability because the haptic is modified L-shaped with serrated edges. I will show you in the video also. Whereas in all the premium IOLs they have modified C-loop and only a part of that touches the capsular fornix. But in this IOL, whole of the 6 millimeter of the haptic, it is in contact with the capsular fornix, and that gives it a rock solid stability. So shall we start, ma'am? Yeah, yeah. Okay. Yeah, yeah, yeah. Sure. No, I will fast forward. So this was a great. Yeah, yeah. I'm fast forwarding. So this was a grade 3. I prefer to use 2% HPMC over the cornea in different steps of the phacoemulsification.
लाइट कौन ऑफ कर रहा है?
So initiation of the rexis, I targeted the 5.25 to 5.5 and it was easily made using the cystitome. In the next case I will show you the sieving needle microcapsular, that was an intumescent cataract. So there were DNB students, so I was doing it slowly.
No, everybody is interested in watching swing needle.
Yeah, I will show each and everything in detail. No, in the next case. This was not intumescent cataract. So rexis was done, then routine hydrodissection, and then it was fully rotated. And now I prefer trenching, first trenching. So with the power setting of 60 to 70% and low vacuum of 150 and flow rate of 18 to 20 for the trenching. And this is the Mohan Rajan sharp chopper for the vertical chopping. So a deep this trench was made. Then coming to the phaco 2 setting. Yes. So this is vertical chopping. It is divided into 2. Now I will change the chopper because I need to go behind the equator, and we cannot take this chopper behind the equator. Why? DNB student? A simple. So now I will opt for the blunt terminator chopper. Yes, you will get the prize. Answer. So this is the, you can see.
Everybody is involved in this.
Yeah, anyone can answer. Yeah, so it can. Ma'am, you decide किसको देना prize. Ma'am has answered. So now you see how this terminal chopping is done. Only superficial impalement.
So you are using a terminal.
Yeah, this is terminal chopper. Yeah.
So you terminated in a soft cut.
Yeah, it can be done. No issue. So we can go behind the equator and emulsify.
और इसका trick क्या है?
To go behind the equator, I will
Yes, understood.
no, I will re-show.
Means terminator can be.
Yes, you see superficial impalement
Ah,
and going behind the equator
yes.
inside the capsular axis margin. I am not doing it this supracap. Because we are going to the terminal weakest end of the nucleus, that is the equator. Yeah. You can see it is. You can see the tip. It's olive tip, right? So that's why it is. And
Very nice.
no, sir. बीच में चलने दीजिए. So this is the last piece. So then routine IA. I think we can move on. Now coming to the IOL. So this is a subincisional part. Now coming to the IOL part. So it is a 13 millimeter whole length IOL with the optic size of 7.5. So how it will prevent the negative and positive dysphotopsia? Anyone? Why there are positive and negative dysphotopsia? Yes, PGs, DNBs. It's a simple question. Anyone? So all the IOLs, premium IOLs, they have 6 millimeter of the optic. So when the pupil is fully dilated, there are 10 to 20 degrees aphakic area on the temporal side as well as on the nasal side. So when the light rays are entering into different part of the retina, they are inducing positive and negative dysphotopsia. So how to prevent it? We have increased the optic size. So it is pupillary independent, insignificant angle, this alpha and kappa. Even if value of high hypermetropes with more than 0.7 millimeter, it is the kappa and the alpha angle are insignificant, pupillary independent. So this is the reason. And there are no refractive and diffractive zone. Yeah.
That is the thing. But here you are increasing the optic size.
Optic size.
So usually when there is a positive dysphotopsia and the patient complains of dysphotopsia, they just re-enter and place the IOL above the anterior capsule.
Yeah.
So what is
ACIOL
the-
doesn't have any positive and negative dysphotopsia.
But इसमें
इसमें नहीं है ना?
इसमें आप
हाँ,
biopsy कर दोगे
पीछे
तो-
No,
तो
but
भी
sir,
नहीं।
what is the length of the haptics?
6
Optic
millimeter.
is nahi. Length of the haptics.
हाँ,
Size of the haptics.
6 millimeter. 6 millimeter. Give me that lens.
7 plus because it will.
lens आ रहा है।
नहीं वो उनको दिखाना है डायग्राम.
मैं तो परेशान हो रही हूँ।
So अभी कैसे दिखाएं? So and it is available 100% hydrophobic now. Co-MICS also compatible 2.2 and a toric version is about to come. We are developing it. So within
And the material is same.
material is the anti-glistening. It's from Contamac, UK based company who are into this business since last 5 decades. So we are using their material.
Because the optic size is more, so haptics should be lesser in the diameter. I mean,
Yeah.
length.
So, yeah.
And it should crumple into the bag.
Yes,
That is-
exactly. So it is a L-shaped. It is not like a modified. So we have compromised on that thing. We have made it serrated outer edge for rock solid stability, and it is L-shaped. So it was 2.2 and it is 2.6 compatible. The samples, so I enlarged a bit. So straight and then little bit vertical. Yeah. Now you see. It's a very lazy IOL, takes time to unfold, so you have enough time to for the maneuvering. So the first haptic is in the back. Very slow unfolding this IOL. So the trick is there are 2 holes that needs to be implanted in the superior part because it is able to correct the distance, intermediate and near visual acuity by using the patented GRIN technology. What is GRIN technology? That is gradient refractive index. So the 2 superior holes there, the refractive index will be 1.42 and it gradually increases, and in the inferior most part it will be 1.54. So this is how it's able to provide the distance, intermediate and near visual acuity.
Which can be implanted?
No.
Have you done any study?
No. Capsulorhexis, we have
Suppose
done-
we are doing fluorescence smaller, 4.5 or will it go comfortably?
It works well, no issue.
Okay. Because optic size is 7.5 mm, that's why I'm asking.
No, it works very well. At
Okay.
any size of the pupil.
Okay, thanks.
No issue. We can even do optic capture, and even with large PCR, when we can still implant it because of the large optic size.
Index, the technology part.
Technology part?
Yeah, can you re-explain the variable refractive index technology?
Yeah. So all the premium IOLs, how they are able to provide this distance, intermediate and near vision by using the diffractive zones or by apodization of the posterior surface, right? So that's why they have halos, they have glares, and these small size they have negative and positive dysphotopsia. So this is there are no rings, there are no refractive diffractive rings, right? So there are two holes that needs to be aligned in the superior part. This is the only trick. It has a learning curve. You need at least 7 days to get acclimatized to it. So the superior holes, the refractive index is 1.42. How it is able to correct all the distance, intermediate and near vision? By the patented GRIN technology, GRIN, that is gradient refractive index. Superior part 1.42, and it gradually increases to 1.54 in the inferior most part. So this is how it is able to provide the distance, intermediate and near vision. You talk about the myotic pupil, so all the three zones are still present in the 0.9 millimeter pupil. And in the traumatic mydriasis cases, the Uretz-Javalia syndrome, where the pupil is dilated 6.5 millimeter, so its functional optic is 7.3 millimeter. So it works well. Yeah, we can say that some part. Yeah. In the superior part, sir. No, they were clearly seen, sir. Yes, you can see here hole. You can see there. Screen is not so good. It is clearly visible under the microscope.
अच्छा अपने को दिखा दो हार्ड कैटरेक्ट
Yeah. It's rock solid because the whole, this L-shaped serrated zigzag edges, so whole of the haptic, 6 millimeter haptic, there is no IOL in the world in which the whole haptic is in contact with the capsular fornix. It is the only IOL, and it is made in India, 100%. No, it's not required. Just even if there is a tilt of 10 to 20 degree, it doesn't matter. It's a forgiving IOL. Even if the IOL power is 1 or 1.5 here and there, it is a very forgiving IOL. Why? Because the depth of focus is plus 1.5 to minus 3. There is no IOL in the world. Such excellent depth of focus. You check in those two patients. DNB students, kindly check depth of focus in both the patients. You will get to know.
So sorry to ask the same question again. So that variable refractive index is from periphery of the lens to the center of the lens, or from 12 o'clock to 6 o'clock?
Superior to inferior.
12 o'clock to 6 o'clock.
Yeah. So it doesn't require this even this neuroadaptation. It can be put in the patient who has previously implanted with a monofocal or with another refractive diffractive premium IOL. And they are excellent choice for the night drivers also. Okay, coming to the, you can see now the combination of these different technique. Grade 3, the cumulative dissipation of energy is only 3.64. So this is the use of the different chopper. So we can minimize the phaco energy. Shall we start next case?
अभी we are going to show swing needle.
स्विंग नीडल या आयोल नहीं आया क्या?
अरे आ रहा है भाई.
क्या कर रहे हो?
आयोल को क्या कर लिया तुम लोग? तुमको किसको बोले हम आयोल?
बेटा ये कैसे होगा? ये बंद करके दूसरा चलाना. इसको बंद कर. So this was an intermittent cataract. Yeah, sure,
Come.
sure.
Past precedents.
अच्छा हमें आना
थोड़ा वीकली हो रहा है. Finish.
क्या अरे नहीं
आपका आईओएल आ गया.
डिस्ट्रीब्यूट तो आपको करना मैम इतना क्वेश्चन पूछे हैं मलय सर एक तो दीजिए उनको
हमसे नहीं पूछ रही सर. आइए बताइए.
मलय सर ने सबसे ज़्यादा क्वेश्चन पूछा है
आओ आओ. ठीक है, नेक्स्ट सर्जन साइंस में 90 मिले.
नहीं मैम फिनिश बस आप स्विंग नीडल दिखा रहे हम आ जाएं इनोवेटर तो आ जाए इनोवेटर आ जाए आप दे रहे हैं आप दे रहे हैं इनोवेटर
गया
Fourth innovation, sewing needle.
स्विंग नीडल देखो भाई सब लोग स्विंग नीडल लाए हो ऊपर दे दिया
ऊपर है. So, yes, DNB student, what are the reasons of Argentinian flag sign? Why it happens?
If you don't reduce, if the ILP is not
It's only the high intraocular pressure or anything else?
high intralenticular pressure.
What else? Mike, please.
The sudden release once we puncture or begin the capsular rhexis, it's a sudden release of the pressure which causes the capsule, very thin capsule.
So commonly we are using a 26 gauge bent needle. It has irregular shape. So it makes, when we are entering for the very first time, it is making 3 irregular entries, right? So now you see that is also one of the reason, along with the higher intralenticular pressure of the extension, because the initial prick we are giving is not regular, it's not round, right? So what we have done is Dr. Rajendra Prasad sir's innovation. So this is how a bent the sewing needle used by our moms and grandmothers. It's just like you will see in this video. Yeah, you can see. So it is round, regular, and with a sharp edge, right? So we need to go in the center and give a prick. So the whole liquefied cortex, it came out, and the opening was very round and regular, just like a small microcapsulotomy. Therefore the name is sewing needle microcapsulotomy. So this is sewing needle microcapsulotomy. First 5 degree tilt, enter into the anterior chamber, then straight, and then prick. No, we have made it, no? Just like a chopper, we have made it. It's very large. Yeah.
Can I speak? Actually, I've been using this for the last 2 years.
Very good.
And this thing, Epsilon company. And I raised the flap also with this. I
it
make
can
a
be done.
section, I raise the flap, then I use my uterta caliper.
Yeah, it can be done.
That is what I said.
Yeah, yeah.
Like you came out now, we can raise the flap and then we can.
Yeah, we can do. So then a routine rhexis was made. Nucleus was freely rotated. So as it was very soft, so I changed the technique into the stop and chop. So I made a very good trench, and then using the terminator chopper and the dialer, it is divided into 2 pieces. 2 heminucleus quite easily. And then again I use the Mohan Rajan chopper as the pupil started to constrict, and it was non-effective by using this Phenocaine Plus also. Very less power, it's only the vacuum. And all the maneuvering mostly in the central part of the pupil. And as you can so there was no cushion, no cortical cushion, so I was very gentle with the last piece.
आप एक ये बताइए, how you use, yesterday you got lot of tips, how you use both the choppers?
I showed in the first case, na?
हाँ बताओ मेरे को बता
So,
हाँ देखो देखो भाई 2 choppers are used at the same time हाँ बताइए
वीडियो
आगे समझिए।
वीडियो दिखाए?
हाँ एक दोनों चॉपर वाले दिखाइए
हाँ हाँ, वो पिछला वीडियो है.
हाँ 2 choppers एक साथ
या.
एक पर रुक जाओ।
या, श्योर.
भाई प्रेसिडेंट इलेक्ट आए हैं खड़े होके स्टैंडिंग ओवेशन दीजिए खड़े होके स्टैंडिंग ओवेशन दीजिए आइए भाई प्रेसिडेंट इलेक्ट हैं साथी डॉक्टर इनको काटी विश्वास एक और आओ भाई एग्जीक्यूटिव बॉडीज आइए रिवर्स स्माइल बॉस के सामने भी ये सब
Dan chopper. आप 1.75 रखिए, कोई नहीं.
अब देखो जो भाई दोनों चॉपर का कॉम्बिनेशन दिखाइए प्लीज बी अटेंटिव सी द कॉम्बिनेशन हाँ बताओ
So after a trench, so I'm using the Mohan Rajan chopper, vertical chopping, lateral separation, and now I want to go behind the this equator. So I will be using a blunt chopper, that is by Dr. Rajendra Prasad, that is terminator chopper.
means you have used 2 choppers
Yeah.
the first chopper is used to divide first
Yeah, first crack
after trenching
after trenching.
and after the first crack is completed
Yeah, it's complete.
now
Yeah.
you are using the terminator
Yeah,
chopper.
it's a blunt olive tip chopper.
but Rajendra Prasad has 2 chopper now one is a soft
Trishul.
no the for soft cataract terminator can be used you said
Yeah.
so now behind the equator
So now you see only the superficial impalement of the phaco, this tip, superficial impalement. I am going behind the equator and it is divided into 2 pieces quite easily.
the superficial impalement
Only superficial impalement under direct visualization, because we cannot use the sharp chopper in such condition. And you see the grade 3, the CDE was only 3.46.
okay
So it's very endothelial friendly, energy savvy. हाँ हमारा हो गया.
swing needle हो गया ना you saw
4 innovations.
so 4 innovations बताओ 4 innovations so you saw you witnessed the 4 innovations बताओ
So first was the Mohan Rajan, the sharp chopper. Then the the second innovation was the terminator chopper. The third innovation was the swing needle microcapsulotom, and the fourth innovation are intraocular lens. The world's first polyfocal progressive intraocular lens with no negative dysphotopsia, no halos glare.
so now I invite Dr. Partha Vishwas for his presentation
आपका लाइव सर्जरी जो की है ना वो नीचे आ गया.
नीचे आ गया. नितेश,
Yes, sir.
नितेश, नीचे आ गया ना डॉक्टर भारती?
आ गया man. I had seen. I checked. It's there.
बीजी लोग कुछ बोलो, बढ़िया कुछ नहीं बचा हुआ है कुछ.
क्या बोलो, तुम तो कुछ पहले बोले नहीं. उनको द ग्रेट मास्टर डॉक्टर अरविंद कुमार मौर्य के बारे में कुछ बताया नहीं. इज अ ग्रेट इनोवेटर. ही हैज इन्वेंटेड सम काइंड ऑफ अ ग्लोकोमा ट्यूब. ही हैज इन्वेंटेड सम काइंड ऑफ lenses, and he has invented these choppers and all that. He's a great guy, and I always meet him in the conferences. His lap is full of prizes. Prize number 1, 2, and इतना जगह नहीं होता कि कहाँ पर रखे इसको. And then I don't know how do we manage the aircraft. But do they allow you to take those things or not? So you are a great man, a great person. Whenever you go to any conference, meet him. And so is our friend Dr. Partho.
Your batchmate.
And he is always smiling, but when on a stage he'll not smile. He'll not smile. And he had yeah.
Yes.
And his all his papers are so well presented, so well read, and he's a great man. And it's so fortunate that we have him as a would-be president of all India body. And great is the land of Mamta Didi, who has given us so many presidents, Dr. Devashish Banerjee, and then Dr. Bhattacharya, and then Samar Basak, and our Partho. So one of the would-be president is with us, and please listen to me. Listen to him. He's a class person, a great surgeon. So one of his surgeries, you will witness that surgery. So Dr. Partha, please go ahead.
So we've been fortunate to be here, and together we were there at St. Xavier's College, and so it's really a homecome back, and it was wonderful to be an operating surgeon once again at Kashyap Eye Hospital, and it's always a pleasure. Dr. Bharti, please pay attention to what I'm saying. It's always a pleasure to be called by Dr. Bharti, who is managing this whole show. So give her a big round of applause. No, very seriously, I must tell you, the meticulous way that she has managed everything, she has invited everybody, she has made everybody feel at home. I definitely belong to this place, but for everybody else, she's taken great care. It's the whole team, of course, but she, with her passionate indulgence, has been in the forefront of everything. So really thank you, Bharti. And this is the love that exudes out of Jharkhand, which is so true to the eastern part of India. So you will go back with memories, Bharla and Arvind.
Sir, everybody's coming. 18 people are coming.
18 people.
Today.
18 लोग को जो है
18 नहीं, आज 20 लोग आ रहे हैं.
अरे बाप रे.
21.
21 बढ़ते जा रहे हैं.
आज 21, कल 2.
Okay. So 23 people, it's become a national conference, and that's really wonderful. So the best thing is, let us make use of each other, let us discuss. There are so many innovations. Arvind has really been a great innovator, and these innovations are some things that we must carry back home. The lens that he used, the autofocus lens, is ingenious lens. We need to know more about it, we need to use it, we need to see the quality of it, and it's made in India. So these are the beauty, and Dr. Rajendra Prasad is Akshay को तुमने welcome नहीं किया?
अरे नहीं जो करना है भैया. आओ अक्षय please come.
Akshay, please come.
And our organizing secretary Sujay Samantha, it's such a nice compliment. Akshay, please madam, hero लग रहा है, model लग रहा है. ऐसा बॉडी बिल्डिंग वाला फोटो भेजा अक्षय तुम अपना. सर, last presentation. सर, हम आपके से आ जाएंगे. Yes, go.
So we'll all need Akshay's help for our baggy eyes at one point or the other. So Dr. Bharti, at one time you'll also need Dr. Akshay's help. Do you accept that or not?
Yes.
Yes.
Aesthetics.
Absolutely.
Yes.
So let's go down to the surgery that we did today. So this was, it's nothing very extraordinary, and it's nothing very extraordinary, but what I definitely used was an extraordinary microscope. The microscope was a brilliant microscope. Again, it's one of the best of its kind, and today, as we know, that we are spoiled for choices. So you have the Lumeri, the best with the Zeiss platform, the best with the Alcon platform. What I use today is the Revelia, and it's a very, very good microscope. So if you are buying a microscope, you should take a demo of all these microscopes. Be satisfied with the quality. Even if it's a phaco machine, be satisfied with the quality of the phaco machine, how well you can adjust to it, how well you can understand it. And these equipment of today give you a lot of improvement on your skills. The skill is always there with us, but the equipment enhances the skill and enhances the way that we treat our patients. It's not only the speed, but also the quantum of energy that we are pumping inside the eye through the microscope, through the phaco machines. And look at this brilliant, bright clarity. And so you can see everything. In fact, you can see more than what you want. So once you have done a cleanup of the cortex and everything, those thin fibrils, which you really don't need to take out, stand out so bright and clear that you have the opportunity to take it out, but again, it's a risk at times to take it out. And this is where it becomes easier for our youngsters to improve upon their learning curves. So our youngsters have the facility, and today we met the DNB students at the hospital, and all of them operate on the same systems that we use today. So it's the learning curve for the youngsters are much faster, much easier. Let's talk about this patient. Now this patient is a patient on whom the first eye has been implanted with a trifocal. It was the geometric trifocal from Hoya. So the second eye has to be a trifocal, and in this case it has to be something called a geometric plus. We'll go on to the nuances of this particular lens a little later, but you can see the blades that we use for this patient, and it is the beauty and the smoothness of the cut. And believe me, I have no financial interest, but these blades is 1.2. So a 1.2 blade, and the side port blades you will not be able to make out next day because of the clarity of the incision. And you will always find a difference between a badly made blade, which makes a side port and the main port, and a well made blade which makes a side port. So it's you who will judge where you can actually incorporate these wonderful equipment into your practices. Now we put in, this is done on topical, we put in a bit of trypan blue so that the stain gets on, and because it's a demonstration, so we do definitely now. Look at this. So what have I done? I've done something wrong here. So look at those air bubbles. I was not diligent enough to take out those air bubbles before I injected. And so these air bubbles, can you get away with these air bubbles to do a good rhexis? You can. But it's always best that you remove these air bubbles, because these at times will float in front of the rhexis or the margin, and that will become unclear. Now these are very small things that I'm telling you, and it's mainly for, I see two bright young faces of residents, but it's not absolutely for the rest of you who are seasoned eye surgeons. But it's important to take off these air bubbles if you want a good clarity during the rhexis process itself. So we put in a little more viscoelastic, and this patient has one big ailment, that's the endothelial cell count. The endothelial cell count was 766. So that's a low endothelial cell count, and we have to be very careful about the cornea and the endothelium. So what we did in this case, and we saw the excellent surgery that was done by Dr. Bibhuti in the first eye without any decompensation, absolutely 6, 9 and 6 vision. So we remove this air bubble, and after removal of the air bubble, so you can see that what we have done is we have put in the high molecular weight viscoelastic and chondroitin sulfate, and then placed methyl cellulose in the middle. So why did we do that? Again, this is very, very basic stuff, but it's for the residents. So we did that so that it's a sandwich of both sides. Sandwich so that the chondroitin sulfate goes and sticks to the endothelium and protects it, and sandwich so that the methyl cellulose, the lower part, is still chondroitin sulfate, and you can see a very well controlled rhexis that I'm doing. It's not a very optimally well dilated pupil, but it's good enough. And if a pupil is of this size, then what you can definitely feel that this might go into a pupil that can become smaller with the management of the nucleus and the hydration of the anterior chamber. Now we are trying to make as round a rhexis as possible, so it's a rhexis that you can be sure of, and the chondroitin sulfate creates a drag. So the movement of your cystotome or your utrata, whatever you're using, is going to be different when you use a cystotome to a utrata in a chondroitin sulfate in a situation where Helon GV is used, and in a situation where it is methyl cellulose. Again, very, very basic stuff, but this is important to note that if you have not used Helon GV and you suddenly one day use Helon GV, the whole equation, logistics of a cystotome rhexis is very, very different. So you have to be particular on what molecular weight viscoelastic you are using. So we did gentle hydrodissection. Again, here it's important to be very sure that the hydrodissection does not, it's a softish nucleus, grade 1, grade 2. The hydrodissection should be just that, so that the nucleus doesn't tumble out because it's a soft nucleus, and we are able to get a good rotation. Again, in a pupil where we apprehend that the pupil might shrink, it's best that the first thing of the nucleus management is done fast. So what's the first thing? Is to division. The other thing is, because it's a soft cataract, the best thing would be to divide this or to do a direct chop. But as we all know that a direct chop at times is not so easy in a soft cataract. It's much easier in a harder cataract. It's quite easy in a grade 2, grade 3 cataract. So here, of course, we will try and do a straight chop, a direct chop. So if we can get a heminucleus of this nucleus, so half the Rome is conquered. And that's what we will try. So again, let's remember there are so many ways to skin the cat, and what I do take is the Sinski, and we have an IOP of 40. I operate usually in an IOP of 30 to 35, but this is what we used for this particular patient. And this good IOP control is something that's really, really ingenious. So you can see that I'm going into the depth, and the vacuum is just about building up to 300, and then we do a straight chop. I have done a straight chop. It has a direct chop, and you can see that once we open it up, it opens up very well. But that's only to the half of the nucleus. So the next part is not doing a chop, but just separating. And at this point of time, in these soft cataracts, it's quite important that we don't curdle up the nucleus much, because we need to get a firm grab on this. So you can see that, with a vacuum a little on the lower side, and the Sinski going right to the periphery, and a straight line for the nucleus to be made, and then the separation. The separation is being made manually between the quadrants, so that we are not, we don't mess up with the nucleus. The moment the nucleus gets messed up, you have a ball which is sitting tight there, and every time you try and take it out, the ball becomes thinner, but the nucleus doesn't come out. So again, these are very, very basic things, again, what I'm trying to tell you. And because remember, we must remember that this patient is a low endothelial cell count patient, so time and again we are putting in the viscoelastic chondroitin sulfate and trying to protect the endothelium as much as possible. Here again, I'll tell you a telltale sign again, which is known to all of us. If you see that the cornea in a compromised case of corneal endothelial cell is getting cloudy, you will know that next day this is not going to be a crystal clear cornea, because the hydration of your BSS, we used BSS plus in this patient and extra protection. So the hydration itself will be such that there would be some amount of edema, and that edema will persist next day also. So here we don't see the edema occurring. And see, it's so easy once the fragments are made, once the 4 chops are made, and it becomes a very, very easy system where you can actually take it off. And we are using the quadrant mode, the taking of the pies, the 4 pies. And the other thing, the apprehension that we had for this patient, the pupillar dilatation is getting maintained for 2 reasons. So the first reason is the chondroitin sulfate that we used for the as a viscoelastic cover for the endothelium also creates a tamponade or a pressure on the iris itself. And since that is being done, so the iris is not fluttering or it's not crowding in, and we are able to maintain an iris size, a pupil size of this. इसमें आगे So again, we have got all the nucleus management done. Now the rest of the part, and we've been told time and again, and this is again for our residents, that when is the time that the maximum PC rupture occurs? When? Madam, the 2 young faces, are you juniors or are you seniors? I do not know. DNB students. You're DNB students? Chalo, answer. Last piece. Which stage the PC rupture occurs most?
While
Removing?
endonucleus.
Epinucleus, you mean, na? Removing? No, जोर से बोलो यार. Epinucleus removal. हाँ, आप बोलो जी.
So during aspiration phase of eye.
Absolutely. It is during the aspiration, the irrigation aspiration of the cortical matter that the maximum chance of a PC rupture occurs. Huh? Yes?
Sub-incision.
Absolutely. You're very, very correct. So here, because we are using the irrigation as... Huh? Fantastic. 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 So residents keep on listening to all the answers, the questions and the answers. Yes. Subincisional cortex is very easy to take off when you're using the IA cannula. It becomes a little more difficult when you're using the coaxial. However, the coaxial also can be improvised to take off the subincisional cortex. How? You need to rotate the eyeball a little. You're able to see the rhexis margin. You're able to go down a little and then remove it. So all this is a matter of learning, which you have to consciously learn. Madam here and madam there, I mean, it's, blindfold, they would do cataract surgery for patients like this. But it's important even today for every one of us to be meticulous. Why? Because even all of us cannot boast of 0 PCRs. Can anybody boast of 0 PCRs? Only one person can boast. Somebody who does not do a surgery. So again, I'd like to show you this part. Again, now this is the Geometrix Vivinex lens. Now look at the system with which we are doing. So under the irrigation, we are implanting the Geometrix lens, and this goes in very, very well right into the capsular bag, and into the capsular bag we have placed it. The next part is also, there is no viscoelastic that is to be removed anymore, because we have not pumped in viscoelastic inside the bag at all. So again, it's safer for the endothelium. And look at that pattern that you can see. So the next part is quite simple. So how many of us inject moxifloxacin in the eye? All of us. Madam, you're yawning. Moxifloxacin आप डालती हैं कि नहीं डालती हैं? Never, never. So Arvind doesn't use, Madam does not use, but large studies have been made. Arvind Eye Hospital study, Haripriya et al. So does definitely have proved that moxifloxacin is something that is to be used post-operatively, intracameral, and I use it. It's a matter of choice. Arvind would not have endophthalmitis also, and you would not have endophthalmitis as well. But it's a study that we don't need to replicate in our system, but incorporate whatever the study tells us. So now this done, what is again very important at this stage? Residence. Bolo. What should I do at this stage? I put in moxifloxacin. How do I close it? How do I know that it's a tight closure? Stromal hydration done. Done. Residence बोलो यार. मैडम क्यों बोलेगी? मैडम क्यों आप बोलेगी? आप बोलो. Is it important to have a tight closure? Is it important to have a tight closure? हाँ या ना बोलो तो. Yes, हाँ. It's important. Why it's important? क्यों? Microbes कहाँ हैं? भीतर है या बाहर है? अगर है तो बाहर ही है ना? So if the speculum is loosened, if the eyeball tension, intraocular tension becomes less, there is a possibility that it might go in. So hydration is a very, very important part and should not be neglected at all. So a good hydration, I always have this habit of checking the intraocular pressure by just a little bit of finger pressure to see whether the hydration is good and proper. And there's another thing, overzealous hydration can also be disastrous. Why? Tell me. जबरदस्त एकदम हाइड्रेट कर दिया, टाइट कर दिया, Descemet's membrane getting detached. चलो, what, madam? Do you have to answer all these DNB questions? Absolutely correct. So these are not only DNB questions, but these are practical aspects we need to remember. CRAO has been reported, and has been reported not only post-cataract surgery, but post-intravitreal injection. Or एक DNB question. Which intravitreal injection can possibly cause this over-inflation or over-injection of the anti-VEGF? Which anti-VEGF? Rupak is smiling. कौन सा anti-VEGF में ज़्यादा रहता है? ये तो बोलो. हाँ. बेवैसेसमैब में तो जितना भी टानो उतना आ जाएगा. Eylea, है ना? So Eylea is very expensive. So what can actually happen? You take out and you have nearly 0.1, more than 0.1 ml, and you don't want to waste it. Push it in and then see with the finger. माता जी दिख रहा है? कुछ नहीं दिख रहा है, सब अंधेरा हो गया है. CRAO, right? So immediately what you need to do? AC tab, great. Absolutely so. So very, very small things, but again of importance, of practical importance to all of us. Let me tell you, I think we can stop the video now. Let me tell you a little more about this concept of geometric plus. Do we have time? I don't know. Kashyap, do we have time? Lot of speakers. In 2 minutes, I'll just talk about this geometric plus and geometric concept. So, have you heard of geometrics, residents? You have seen the injection of geometric and geometric plus, right? So, what is the difference between them, and why does the manufacturer, why do they have come up with such a concept of a particular lens in one eye and the other eye being another lens? It's the same lens. It's called geometrics and geometric plus. Now, geometric is supposed to give a light distribution which is high for the distance, approximately 58%, something of a 58%, and intermediate and near, the light distribution is less. The near is approximately 12% or 14%. Whereas the geometric plus, which is supposed to be inserted for the other eye, has a light distribution that is more for the near, around 26%, and less for the distance. So it's a combination, and a binocular function of this gives a better contrast sensitivity, a better binocularity, a better see for the distance, middle and near. So this is a concept, and the literature says so, but in practicality, I think a lot of us have used this. Balla, you would have used it. Rupak, Arvind, Kashyap to use karte hi ho. I'm sure all of, how many of you have used the geometric and geometric plus lenses? ठीक है. So I think it's a good lens. Vibhuti, नहीं कर लो यार. मतलब it's Dolly, नहीं Dr. Renu, नहीं Nilendu, नहीं. So it's actually a good lens. It's something that you can use and see for yourself the benefit that a patient has. It really is worth the effort to do this, and of course you should not be telling your patients to do right to left assessment, which they should not do. Malay use kiya? Nahin. So this is in short, I mean, whatever we had to say about the surgery as well as about the lens. Any quick questions? I'd be happy to answer, and then leave it to Roop. The stability of the IOL. So again, this is an acrylic hydrophobic IOL. The centration is excellent. The injection system of this particular manufacturer, again, no financial interest, it's one of the best. The smoothest, 2.2 millimeter incision. You don't have to struggle, you don't have to extend. Aram se it just goes in, and the injection is super, and it goes in for all the Vivinex series. So again, the stability, and if it is a toric lens, the stability is also very, very good. And the Vivinex or the Geometrics also have the toric platforms. See, obviously, yes. Now, one quick question. So, in the particular machine that I use, Centurion, ठीक है ना? So, the Centurion, how many of you are users of Centurion? Kashyap mein, हाँ, सारे को. So, how would you use a BSS Plus if you wanted to use? So, it becomes difficult because it's a pouch, and the BSS Plus comes in a different pack with the glass bottle. But what you can always do is the glutathione, the vial, you can inject it into the plastic container as well, and you can definitely go ahead and do a BSS Plus of these. Any Malay? Yeah, so you know, when we first did our around 10 to 15 lenses, then we asked these patients, and they were executives. We told them that this is the concept. We told them, please go on to the literature, please go on to your Google search and read about it. So these are two lenses, and this is how it is going to help. And these executives actually said that yes, I'm there for this lens, okay? And then we implanted. So they would be driving at night, they would be doing laptop, computers, everything, and around 10, the first 10 whom we did, so we asked them very specific questions. We had a questionnaire, 4 or 5 questions, simple questions. Is, are you able to drive well? Are you able to do your near vision work properly? Are you able to see clearly at night? So all of them were very happy with the binocularity. Some of course said कि थोड़ा सा कैसा difference तो लगता है. So between the two eyes. So that's something we need to educate these patients before we actually put in the lens. Again, it's very important to tell about the concept of geometric and geometric plus. Don't leave it to your counselor all the time, because you know patients are not used to this. उनको तो वैसा नहीं लगाया, हमारे brother-in-law को तो ऐसा नहीं लगाया, things like that. So let us be very genuinely honest and say that this is what and this is what we are giving you. It's not a question of mix match, it's a question of the light distribution. So because it's the light distribution of the distance, middle and near, so that is how the binocular system is able to adapt to it very fast. So in mix and match, patients are not initially very happy. So you have reduced the diopter by say 0.5 or 0.75, and you're trying to give a distance and a near. Here the distance, middle and near is done for. It's the light distribution which makes the difference. So that is the difference in the concept basically. It's as soon as possible, जितना जल्दी हो सके. एक वीक का तो बोलते हैं, लेकिन एक मंथ में भी some people say कि नहीं नहीं मैं बहुत अच्छा देख रहा हूँ. Another thing, of course we know about the trifocals here, that if it is a patient who has one eye 624 and the other eye 69, please be very sure that you counsel the patient yourself about the 6/9 good eye and the 6/24 where you're going to give a trifocal. Patient is going to complain, ये आँख तो ऐसा दिख ही नहीं रहा है, अच्छा तो दिख ही नहीं रहा है. I'm sure all of you have had this thing, and especially if it is a patient, a young age patient with a traumatic cataract. Do beware of such patients, because the expectation is sky high. नहीं हमने तो सबसे best lens डाल दिया है, फिर भी क्यों नहीं इतना अच्छा दिखता है. And I have a particular patient who eats my head even today after 4 years. So these are things that will occur. Very good question. Very, very good question. So geometric in the first eye should be there. See, the distance is what everybody wants first. मतलब बढ़िया दिख रहा है. And they are concerned about the near, but when the binocularity comes, so second should be the geometric plus. Second should be the geometric plus. The other question, a corollary to this, is can you put a geometric and a geometric in both? You can. But then the benefit of that light distribution is not going to be there. Yeah, so dominant eye again, distance, geometric. Myopic patients, be aware of the myopic patients, because again, you might not be spot on. It might be a big bag syndrome, it might be less, you might be erring, and of course, use the optical biometer by all means. So how many of us use the optical biometer? Balla? DOS ka boss? I can. अभी तेरे को मैं कोर्ट मार्शल करता हूँ, कल इमर्शन यूज करता है. DOS का बॉस ऑप्टिकल नहीं यूज करता है.
Sir, the optical biometer,
और
everything has been based.
नहीं,
all the studies have been based on immersion
नहीं
reading,
मानेंगे. कितने लोग नहीं मानेंगे? हम तो दोनों हाथ में उठा देंगे. नहीं, see, again करना पड़ा. ठीक है कश्यप जी, जब आता नहीं है, ठीक है, आपने गेस्ट को तुम प्रोटेक्ट कर लो, मैं समझ गया. हाँ, जब आता नहीं है तो you have nothing but immersion. But let me tell you again very frankly, the optical biometers, it's proven. Again, you don't need to do a study for this. It's proven that the amount of precision with the optical biometer is definitely more. But again, there is a time lag when you're doing an immersion. Your optometrist or biometrist has to be well trained for that. चलो मैं बहुत समय खा लिया. Kashyap, sorry. चल.
अच्छा.
So I would like to introduce Dr. Akshay Nair here. So he's a oculoplasty surgeon working in Mumbai, and he has built up a very nice center there. And generally people find it difficult to work in or get trained in one premier institute. He has been trained in 3 premier institutes, so that speaks about his caliber. And he is quite, I think, he has made a name for himself in the India as well as the international academic circle. And he holds so many posts. He's in editorial board of IGO, and he has Young Ophthalmology Society sessions. Even in OPI, he's quite popular, and he operates quite well, as you will see. And he writes very well. He publishes very well. He speaks so well. So I think he does very well in life, and I think he has got excellent sense of humor also, above all. So I hand over the podium to him.
Thank you. I like it when the crowd has such few oculoplastic surgeons. I can get away by saying anything. Nobody is there to correct me. So Malay, if I say something wrong, don't point it out. Alright, so ma'am, Dr. Bharti ma'am specifically requested that we wanted to get a case of a ptosis where we'd be able to do a Mueller's muscle resection. This is a kind of ptosis correction surgery, which is also known as a posterior approach ptosis surgery. And as you will see in the video, we approach the eyelid from the conjunctival side and not from the skin side. The skin side is of course a classic levator resection, but there are only specific indications for this. So this is something where we do it in cases of mild or moderate ptosis, and it has a fixed normogram, and I'll come to that. And the most important thing is a phenylephrine test. Very often we see patients whom we've seen undilated in the clinic, and then we put in a dilatation drop, and they come back with big lid retraction as well as a blanched conjunctiva, and that's the effect of phenylephrine, because that is the Mueller's muscle. So Mueller's muscle basically is a small strip of vascular muscle which is on the superior surface of the tarsus up to the levator, and this specifically has adrenergic receptors. So when you put a drop of phenylephrine, it contracts and lifts up your eyelid. So if you see a phenylephrine positive test, which means that when the Mueller's muscle contracts, the eyelid lifts itself. So we know that now if you were to remove this Mueller's muscle and stitch the eyelid back in position, his eyelid would remain the same where it would if you were to get a phenylephrine positive test. So positive phenylephrine test is needed for you to go ahead with a Mueller's muscle excision or a conjunctiva Mueller's muscle test. So how do we do this? The same dilatation drop that we have, T plus phenylephrine plus tropicamide, because plain phenylephrine is difficult to get. We put 2 drops in the conjunctival cul-de-sac 10 minutes apart only in the ptotic eye, and then we see that it goes up, so we know that okay, it's a phenylephrine positive test. When it lifts up by 2 millimeters, the action of the Mueller's muscle is only to lift the eyelid by 2 millimeters. So if it is more than 2 millimeters of ptosis, then a Mueller's muscle may not be a great option. In those cases, you may want to do an anterior segment set.
please, you work for the society. So Akshay, sorry for disruption. Sorry.
Good. So in case the interest was waning, suddenly now people are alert and now their interest levels has come back. I'll come back to my video. So an entire ptosis surgery, it takes about 30 minutes and I don't want to keep you all waiting. So what we've done is managed to just keep the relevant parts in this video. It's still about 8-9 minutes long. So the block that I give is a frontal block. So the entire eyelid has sensory innervation is taken care of and it's lost. It's important to take these traction sutures that are through the lid margin. The suture material that I'm using is 6-soap silk. The traction sutures help you in everting the lid and also give a lot of stability. So I like to take 3 traction sutures so that the lid is optimally pulled across all 3 directions. Right. So once this is done, the lid is then flipped over. Now the nomogram is for every millimeter of ptosis that you need to correct, 4 millimeters of Mueller's muscle has to be removed, or 4 millimeters of conjunctiva and Mueller's muscle has to be removed. So based on that principle, so if you are correcting 2 millimeters of ptosis, 8 mm of conjunctiva and Mueller's has to be excised. So that is the marking that we do. Now you can see we'll flip over the eyelid using a Demar's retractor. And what you see there is the tarsus. So the first landmark that I mark is the lower edge of the tarsus or the inferior border of the tarsus. So that's the lower edge of the tarsus. Now if I were to mark 4 millimeters from this, so what I do is if you are excising 8, half of 8 is 4 millimeters. So from the edge of the tarsus, I'll mark 4 millimeters. And that's my point. So I mark all along the upper eyelid so that we get a clear line. And then what I do is we pass a suture through this point. And again 3 such traction sutures are passed in this way. So now if I were to lift up the eyelid or the conjunctiva from these anchoring points of sutures, you can imagine 8 mm of the conjunctiva is going to be lifted. 4 from the tarsal edge to the marking and 4 on the other side because it's a 3-dimensional figure. So I've marked 4 mm here, and when I lift it, 4 mm from here and 4 mm from here, 8 mm of the conjunctiva and the Mueller's is lifted up. So this is the amount of conjunctiva and Mueller's muscle that needs to be excised. But how are we going to be absolutely certain that that is what is going to be excised? That's where we use what is known as a Muellerectomy clamp, a ptosis clamp, a Putterman's clamp. So now you see this is 4 mm from here to here and 4 mm on the other side. So total surface area or the length of the conjunctiva excised is 8. But many times we don't have a conjunctival clamp or Putterman's clamp. So what we use is a mosquito forceps or a simple artery forceps. So that's the part that is going to be clamped. We can use 2 well approximating stainless steel forceps that clamp from both sides such that you have complete clamping effect and hemostasis on both edges. So this is one, and then we push in another one as well from the other side. Now if we were to cut the entire conjunctiva right now, the edges would still not be approximated. So the next step is to pass a suture to make sure that the cut edges are going to be approximated, and that is done with a Prolene suture. So now what I'm doing is passing a small Prolene, a 6-0 Prolene knot, and taking a knot on the skin. And this suture, after fastening it or fixing it at one point on the skin, is then interiorized. So then when I say interiorized, it is passed from the skin side and brought out underneath near the conjunctiva. You'll see this here. I'm passing it from the skin here and bringing it outside through the conjunctiva just next to where the clamp is. Yeah, so the edge has come out on the conjunctival side and I can then pull it out. And the next step is most important because that is where we pass the actual suture of the mulerectomy. So now this suture has been interiorized from the skin to the conjunctival side, and now it is passed in a serpentine fashion, which is basically underneath the clamp, because now if everything that is above the clamp is going to be cut, you need to make sure that the cut edges are approximated. So I pass it from the front to the back underneath the clamp, and then take it out from the other side, and again from the back to the front. So it's like a serpentine fashion that keeps going underneath the clamp right along the entire edge of the tarsus from the left side, from nasally to temporally or temporal to nasal, whichever way you're passing it. So it comes underneath the tarsus, underneath the clamp, making sure that it's flush to the surface of the clamp and not too far away, because you want the approximation to be perfect. And now again it passes from the anterior surface, from the front to the back. So it's a serpentine fashion that goes. And finally, when it has reached the other edge here, now once you have passed it entirely serpentine in a fashion from one edge of the tarsus to the other, I push it back and exteriorize it again. So now it is passed and brought out through the skin. So basically it's a proline that has gone from the skin and onto the conjunctival side, all along the edge in a serpentine fashion and back straight up. So this has demarcated and fastened the edges which are going to be cut now. So now we use 11 number or a 15 number depending on your comfort level to excise that 8 mm of conjunctival Mueller's muscle which has already been clamped and lifted up. Now you want to cut it in such a way that you don't cut any of these sutures that you see there. So you should cut it as if you're trying to blunt the blade of the needle by scraping it against the metal of the clamp. Now this is done. Now the lid is flipped over. So now we've approximated, cut the edges. Now all we need to do is tie the two edges of the sutures here, which are taken off at about 1 week. This surgery is extremely predictable because we know for every 4 mm of conjunctiva Mueller's resected, the eyelid is going to lift up by 2 millimeters. 8 mm resected, you have to have an improvement in ptosis by 2 mm. And of course the proline will hurt the cornea or the surface of the eye. So we put in a BCL, which is removed at the same time when the sutures are removed, and a short course of topical antibiotic and steroid. It's a very, very predictable result. I dare say almost as predictable as a refractive surgery. Again, Malay will not correct me if I say that. Right. So that's our conjunctiva Mueller's muscle resection. It's a straightforward, predictable, safe surgery as long as your measurements are right and you know how to do it. If there are any questions, I'll be happy to take. True. So it can be very, very confusing because you've taken traction sutures, you've taken sutures on that. Especially a first-time assistant who's assisting you loses their patience because they don't know what it is. But each suture is very has a purpose there. Yeah, over time now I will take only one single eyelid traction sutures, but the 3 sutures on the conjunctiva side are needed because that lifts up the Mueller's muscle uniformly across the entire length of the tarsus. So yeah, I think we could reduce the traction sutures, but the lid suture, the conjunctival Mueller sutures are needed, and over time I think it becomes habit to us, so we are comfortable. Yeah. So actually that's a great question. So ideally I'd like to have used straight so that they are absolutely parallel to the surface edge of the tarsus. But if you're using curved, make sure that you don't have you still use the straight tip of the curved scissor and not the curved part, because then you'll have a curvilinear shape incision. And make sure that there is no, over time, using these mosquitoes to clamp linen, to clamp cloth, or to clamp tubes, their teeth get a little splayed apart and they don't hold as well. So you make sure that check the edges of the clamps, that they approximate completely, and use only that well-fitting artery forceps for the conjunctiva. But yes, straight over curved, and if you're using curved, only the straight tips of the curved part and not the curved part itself. Little more. So actually that's a great question, because then that threat of the suture cutting is not there. As long as 4 mm of so actually it's not, as long as the distance between the cut edges of the suture is 4 mm, we are good. So you can mark 4 millimeters, clamp it at 4 millimeters, and then make sure that you cut it. So that's also a good option that they do. That's actually done with the Putterman's clamp, where you pass it that way, and it works well. So good modification. Yeah, I'm surprised, na? VR surgeon giving oculoplastic modifications. True. Next, it's like that. My pronouns are he, she, or they, them. So your pronouns are VR and refractive. Alright, so thank you so much. Yeah. Thank you, sir.
We'll be talking about the phakic IOL. Phakic IOL is one of the very simple refractive surgeries, but then you have to do the measurements, do the investigations properly. Because when I started this eye surgery, I thought the cataract surgery is the toughest. On the top we have got cornea and endothelium, niche we have very less area. In vitreous there is a lot of space, You can even keep the instrument inside and talk to people, but you can't do so even while doing a cataract surgery. So is the phakic IOL. The patient is seeing well. The patient has got a very good vision. When after this surgery, there should not be any complication. You can't afford to have any complication. You can't afford to have that the patient develops cataract. You are done. So you have to be very, very careful. You have to do these examinations, very careful investigations. So in our practice, what we do is, this is our prescription. On the first page of the prescription itself, we write all the investigations, and most of the findings are written next to the investigation, those results. So that if you see the first page, you know what all has been done. If you want to see further detail of those investigations, the results, go on flipping at the pages and you can see. So in this case, we have done all the necessary investigations. The most important investigation is whether the patient should go for a LASIK surgery or a phakic IOL. So it all depends on the corneal thickness, whether the cornea is thick enough to go for a LASIK surgery, and what is the ACD, that is anterior chamber depth or aqueous depth, and then what is the lenticular thickness. And sometimes patient may have to go for a phakic IOL in one eye and the LASIK in the other eye. The white to white measurement is the most important measurement that you have to be very, very careful. And the nearest white to white measurement that comes to the digital one is no financial interest, but then it's anterior. It is almost same, almost same. So after doing all this investigation, we found that the patient requires a phakic in the right eye, and the defective error was minus 11 with minus 50 cylinder of axis 15 degree. Indirect ophthalmoscopy has been done. It was found to be normal, and this is the calculation given by the company people, that is care group. And I wanted to mark one thing, that if the patient's spectacle glasses are, let's say, minus 10, and if the patient is given a contact lens, it is generally less. If the power in the glass is minus 10, probably the contact lens will be of probably minus 8.5 or something. Let's say otherwise also, if the patient is aphakic, he needs a glass spectral power of plus 10 approximately, but if you put an IOL, it's plus 20. So the power becomes lower when you go in front, and more if it goes, the minus power becomes less if you go more towards the nodal part. But in phakic IOL, there is a little difference. The power, the light rays converges through the cornea, with the maximum convergence happen there, and then it has to pass through the phakic IOL. So the phakic IOL has to little diverge more, and then the lens of the person itself, it converges. So if the power of the glass power is let's say minus 1, the phakic IOL power will become something like 12.5 or something like that. So please do not confuse on that, right? So in this case, the power is calculated and found to have plus minus 12.5. And this is our anterior finding, and you can see that the anterior chamber depth is aqueous depth is good. That is the anterior chamber depth is good, and all the companies, they mention their limitation that the anterior chamber depth should be. When I say anterior chamber depth, I mean between the endothelium and the anterior surface of the iris. Some people call it aqueous depth. So some company mention that the aqueous depth should be not less than 2.8. Some mention is should not be less than 3 millimeters. So it is better that the anterior chamber depth is more, but you should not put the phakic IOL if the anterior chamber depth is less than 2.8 millimeters. So all calculation done, white to white measurement is done, and you will see here that the white to white measurement in this anterior is approximately the same what we had got in digital caliper. So this patient was very, very apprehensive. Normally I do under topical, but we had to give him peribulbar. I generally use acryl group, but then I have switched over to care group these days because I find that that's very good. It has got a lot of holes. It is more malleable. The foldability is much better and very easy to manipulate. So my incision is 2.8 millimeters. I generally give incision at 150 degree. Be careful that you do not injure the lens. And a phenocaine to keep the pupil dilated. then put the viscoelastic. You don't have to overinflate. So this is the loading technique. This is the phakical. It has got 4 legs with holes and 2 nose, and there are 2 holes which should be in the below the upper eyelid. I'm going very slow to make you understand, especially to the newcomers for the ophthalmology. And the wings of the cartridge has to be held like that in both 2 fingers. The lens is pressed and pushed between the 2 ridges. And there is a click, but you should not push it to click. Before that, you have to see to it that the movement of the lens is good. So the movement is good, so I pressed it for the click. There is the anterior insertion of the cartridge. Now it is ready to be injected. Please watch carefully now. So while testing the movement of the IOL, I had pushed much more than what was required. So the moment I went to the edge of the incision, the lens came out, so I couldn't put the lens inside. So same lens, but then now I am taking the other cartridge. One thing I would like to explain. So there are 2 holes here. So you have to position the lens in such a way that these 2 holes should be covered by the upper eyelid. So those people who sit temporarily and give incision and temporal incision, so they have to put the lens in a cartridge in such a way that while injecting, these 2 holes should go upwards. Right? So if you insert this in the right eye, you have to be careful. If you go to the other side, you have to orient yourself in such a way that these 2 holes should be upwards. अरे अनिता, तुम कितनी बार कहा करो नाश्ता पानी करके आया करो, अरे जोर से बोला.
बोलो. दूसरा माइक चाहिए?
Hello.
हाँ, yes, hello.
Sir, now because the lens is out and now you have to reload, how can you identify whether the lens is flipped or it is perfectly placed?
No, I have not put the lens inside the eye. This is outside.
Yes. So, sir, how is it like, inverted S we consider like for the.
There is a convexity.
So, the convexity you try it under the microscope or it is very well visible?
It's very well visible. Even naked eye can see. You
Okay,
can see the
okay.
convexity at a 1 foot distance. It's so well convex.
Okay,
Yeah.
okay, great, thank you.
So it is the same lens but a different cartridge I took. So it's so good about the Indian company that they give you 2 lenses. If you are going for one eye, they give you 2 lenses, 2 cartridges, 2 injectors. And when I did this, when I failed, then my company people said, sir, you know what, you should have put this injector, you should have you push the injector and the plunger, with the plunger you should have pushed the eye inside. So I did the same thing. So yeah, see, this is the injector and the plunger. With the plunger I pushed it fully. So it is probably measured, so you'll not make any mistakes. And there is anterior loading. You stabilize the eye with the side port and inject. While injecting, you don't have to go very fast. You should stop in between and see the rotation and those 2 holes. Now I can see the 2 holes. Now I can push it further and the lens is in position. Now the lens, all those legs are pushed behind the iris. So pushing these legs behind the iris is not a big deal. So I'll move a little faster. Now the last haptic, you have to be very, very careful because sometimes because of the incision, the visibility is little less. So you have to be very, very careful. Should you or should you not put the pilocarpine is debatable. I always put a drop, very little drop of pilocarpine, because if you put the pilocarpine and the people constrict, this means that the size of the lens is good. If it does not, it means there is some problem, you're going to have some problem. So if you feel that there is some problem, I do a PBHI, otherwise it's okay. And so then you hydrate the bone. My another point is many people do not put air. I always put air because if by any chance if the anterior chamber becomes shallow, you are in trouble. Number 1. Number 2, if you put air, you see the roundness of the bubble. Then you know that the lens is in position and probably there is no astigmatism. It is not creating any astigmatism. Number 3, if you have put the air, it has to be very less amount, because if you put the pilocarp in and if the air goes behind the iris, there is going to be increased intraocular pressure and the patient will have pain and vomiting and all that, and which decreases after the intraocular pressure decreases. So my point of discussion in this is, this surgery is very easy. Number one, you have to see to it that the anterior chamber depth, that is aqueous depth, should be not less than 2.8 millimeter in any case. Number one. Number two, if you are very lazy, you can depend on anti-tone finding of the white to white measurement. Number three, while putting the lens inside, you must see to it that there is a free movement of the IOL. That is very important. And number four, the last leg, the last haptic has to be very, very carefully put inside. Number five, which is very important, which this patient did not require, was suppose if it were a toric IOL. If it were a toric IOL, push the lens above the iris, rotate the lens wherever the axis is there, wherever you want to tuck it in. So if you have reached that axis, then only you tuck in the haptics. Any question? Thank you. Any suggestion? Arthur? Mic do up here.
Sir, in your experience, what is the incidence of premature cataract in phakic IOLs and to other surgeons also? Premature.
In my experiences till now, I have not had any cataract. Nobody has developed cataract so far.
A good phaco surgeon is deterred from doing a phakic IOL, is it not, Kashyap? So it is this fear that a cataract might happen prematurely, and that is the reason why Vibhuti doesn't do a phakic IOL. So it is like that. But let me tell you, if it is a well done surgery, it's a very, very swift and a very simple surgery. Dr. Kashyap showed exactly the ways that it has to be done. The assessment is very important. And during my learning curve, my third patient, it was a difficult surgery in that the patient developed cataract after about 3 to 4 months. It was because of the bad implantation of the lens. This patient is now being followed up still till date for the last 12 years now. In this time, it's just an anterior cataract and it has not progressed. Unless it is a very, very badly done surgery, and if it is just the one instrument actually did not puncture the anterior capsule, but it hit the anterior capsule while I was implanting the lens. So that was a flaw which I did, but it was an anterior subcapsular opacity which did not progress. So we are using the spatula to tuck in the lens. The haptics of the lens has to be used. Now what had happened in my case, I thought that my spatula was over the lens, but it actually had gone under the lens. Okay, so that was my flaw, my fault, and that's how the anterior capsule was damaged. But it was not punctured, but it was damaged, and that reflected after 3 months with the anterior subcapsular opacity. Leaving that, otherwise, what is the possibility that there could be a cataract prematurely, as you said, if it is a very low vault? Okay, so and that is one reason why both the eyes are not done usually at the same sitting by most surgeons. So you see the vault, it's a good vault, then you go on to the other eye, usually a week apart, but even 3 days or 5 days apart is also possible. So if the vault, I don't know about Dr. Kashyap, but if the vault is less than 100 microns from the anterior capsule, then if it is less, you must explant it. Explant it and put a larger size ICL or phakic IOL. If it is from 100 to 250, which 250 would be a very ideal, 250 to 500 is a very ideal vault position. So if it is between 100 and 250, I have my low vaults, I'm following up for the last many years. Up to 100 is excusable. It does not actually produce cataract. But less than that, there is a possibility that it will. But these low vaults must be followed up very meticulously.
Then
No. Explantation, again, Dr. Kashyap will agree, it's as simple as the implantation, but it needs expertise also. With the same forceps that you put in, the loading forceps, I'm talking about the ICL. So the IPCL is a little different. So there's a particular forceps which can explant it very well. You don't need to increase the size of the incision also, but it has to be very meticulously done. And it is not as simple as explanting a cataract IOL in the bag. It's not simple. Why? For the very simple reason you are working at just about 3 millimeters of space. Crystalline lens, pristine crystalline lens, and the corneal endothelium. So that has to be kept in mind while explantation.
Yeah, two things I'll say that the chances of cataract are there when you injure the lens. Injure the lens doesn't mean that you penetrate the capsule by any means. Even if you push the lens with a jerk and it touches the lens, then can develop cataract. While tucking the haptics beneath the iris, if you injure that, push it hard, you may develop cataract. So, even if you're touching the lens capsule on a harder way, you can get cataract. Number one. Number two, you always should see the vault. If the vault is 100, I don't like it. It should be more than 250. But if it is 100, you don't remove the IOL, no. But then you keep on, counseling the patient that you have to come more frequently, शायद कुछ करना पड़ सकता है. So you don't do anything unless there is some problem. But keep on watching it. And lens removal is, I think it is easier than the pushing the lens inside. Because the pushing the lens inside, you have to see to it that the lens is hitting not below the iris. It has to be at the angle of the anterior chamber. So that then you can tuck it in. So for the removal you just push the near the optic of the lens, and so that at least one haptic comes out. And then with the other hand you just little rotate it. You should be able to grab the lens by a tooth forceps, a simple tooth forceps, and pull it out. It comes out. It will not cry at all. So once you hold it with the corneal forceps, it comes out very nicely.
So you use high density viscoelastic or the same normal method?
Normal.
Why not high density viscoelastic? Because we will get more space. One. Second is it's very important in the first post-op day to see the IOP of the patient. First post-op day. And the explantation is very easy. Day before yesterday I have done one explantation of the IPCL. It is done somewhere else. It's very easy. Just one, you push the viscoelastic under the optics. The one haptic will come out automatically. And then we just rotate it and hold the lens, one of the angle of the haptics with the serrated McPherson forceps. Just pull it, it will come out. It will not touch anywhere.
If you can make the same incision, you can make a different incision. It all depends on you. It depends how many days early it was done. If it is 2 years, you can make the separate incision altogether. There's no problem. So pushing the if there is no cataract, don't try and go behind the IOL, right? It is, you just push the IOL a little bit, and the haptic comes out. Pull it out.
Subrata has got a very good question. Why not why not say Helon? Okay. Now, many people are using Helon these days, and the benefit of using Helon with phakic IOL is it comes out in a bulk. So in a bolus it will come out. Yes, of course, the cost of the surgery goes up a little, but it's easier to remove. He's quite correct there. However, methyl cellulose, again, let's remember that we are placing methyl cellulose in just about 3 millimeters of space. So the amount of viscoelastic that we are using is not too much, and it can come out very well. So just a little, and you can see the strands of methyl cellulose coming out, and once it comes out well, usually you do not have a spike of the IOP next post-operatively.
Those people who are using Helon, anything you do under Helon is entirely different when you're using methyl cellulose. If you're doing Rexis, try with the Helon and try with the methyl cellulose. It is different. So those two, these two things, when you use, you'll have a different kind of a surgical feeling in your hands. So you have to be careful. But then I have never done with the Helon. If you suggest, we'll do it. Anindya, और कुछ पूछो ना. Yes, Rashmi.
Previously we used to do PI, now we have all these holes, but in this particular model, why do we have so many of them?
Yeah, for the good aqueous flow, there's so many holes are made in the center, in the left and the right, and up and down. No. You should not use the spatula near the hole, nor try and remove the methyl cellulose, go near the hole and try and suck out the methyl cellulose. Don't ever do that. It should not be done. Didn't get a second sentence.
No, I'll tell you, it's a very important question. Kashyap, let's answer this question, and full well. IOCare is here? Here or not? You're here. Kyun nahi uthte ho yaar? So, if it is a low vault, right, or a very high vault, and the calculation has been done by the company, and the company has suggested that particular lens, and you have abided by that particular lens, and you have a low vault or a very high vault, they will replace it. Okay. However, if you have overrun the calculation and you have chosen a lens that was a misappropriate lens, and on your calculation or on your supposition, then you are responsible, and the company, not IOCare, the other company will not replace it. So that's done free of cost. The other thing, of course, is ICL. You will get only one ICL, and God willing, it doesn't drop into the floor and you are able to use it. However, the IOCare guys provide 2 IPCLs and the others as well. अरे बोल दिया यार, चलो बैठो.
So, who's the next speaker? Dr. Rupak, we have some problem with your video. Nitesh ji? Shaiban, are you around?
Subroto had a very interesting question. So his question was, if cataract develops after a phakic IOL, so what do you do? So the first thing is, you have detected a cataract after phakic IOL, you are seeing it on the slit lamp, but the patient might not be so disconcerted. Okay, so it doesn't mean that clinically it is there on the slit lamp, means that cataract has come and you have to remove the phakic IOL and do a cataract surgery. Let him wait. The other eye might be very good, this eye might have developed a little bit of error. Give him glasses if he is fine, and then let him carry on till the time that the vision cannot be corrected and the patient says that no, ye nahi chal raha hai.
Means how much vision that needs?
This is very
6, 12,
subjective.
6, 18.
No, Arvind, this is very subjective. Some people will say, नहीं sir, वो तो ठीक है, अभी 6, मैं जो पढ़ रहा हूँ वो ठीक है. So there are certain people who will just go on, even if it's become 6:24 and the other eye is seeing well. So let it depend upon the patient. So let's not take the decision by the surgeon. Depend on the patient to suggest when you'll always have to assure that this is a simple surgery and you will not have to wear glasses once again. So that has to be assured to the patient. Now, since we are talking about the cataract aspects, let us discuss one or two other things as well. So what about the biometry? When we are doing a biometry with a phakic IOL, so this is again a very, very good DNB question. Okay, so how are you going to modulate the biometry? What factor are you going to give? I'm putting a trap for you. This is an important question. Isko to refractive surgery phakic IOL aayega. This is a near actual question that actually is asked. So what's the thickness of the say IPCL or ICL or the phakic IOL? Approximately 100 microns, right? In the optical zone, 100 microns, 120 microns. So you do not have to make any modification of the biometry, right? So it's the biometry which will suffice. Now, the next is more important on the practical front. So what lens do you place in a cataractous eye with an ICL? So patient will always say कि हमें तो सब दिखना चाहिए, दूर का भी दिखना चाहिए, पास का भी दिखना चाहिए. So here again, if you're thinking of trifocals or EDOF lenses, you have to make a very important decision for the patient. Rupak, whenever you're ready, you start. You're finished? You're done? Acha. So again, the health of the macula is very, very important in these high myopes. You must check the health of the macula before thinking of trifocal. So if the health of the macula is good, then you have to again remember that it's a high myope. You might not be spot on or bang on with a trifocal. If there is a doubt, EDOF is a much better option. And if the patient is fine wearing near vision glasses, then even a monofocal is a very good option, where you're giving a full and bright contrast vision for the distance, and the patient is happy to it. Anil.
IPCL not being done for a very long history. Have you met any patient who developed cataract after ICL or IPCL? And is there any changes in anterior capsule during capsulorhexis?
Bilkul. Patients who have done phakic IOLs very long ago, those patients, some of them are developing cataracts, and I will tell you in maybe in 2 months, 3 months, maybe I take out a cataractus lens, the ICL is taken out, the cataract is done. Here 1 or 2 small tips. Rupak is ready. So quick tips: the ICL removal or the IPCL removal best be done from the temporal port. Okay, you put in viscoelastic, you must wash it out. Remember the fact that if you're doing a phaco with a 2.2 millimeters, it's a 3.2 millimeters through which you have taken out the ICL or IPCL. Best is to shift to the superior and do your phaco superior. So, and then place in the required lens, whatever, from 2.2 millimeters incision. No. no changes, rexis, etc. Absolutely same. But remember that if it's a low-grade cataract and it's a high myope, the tendency of running out of our rexis is very high, so you have to be very careful. Thanks.
So moral of the story, Parthoda, is macula should be okay. Whatever you do, the macula should be okay. Unless until the macula is okay. So whatever you do, चाहे वो multifocal हो या monofocal हो या 100 focal हो, आपका वो macula ठीक होना चाहिए. Otherwise, it will not get focused over there. So let us talk about the repair of macula. I'm sorry, first of all, I would like to congratulate Dr. Kashyap, Vibhuti and Madam for excellent this organization and excellent hospitality. Sorry for that. Take it to the reverse way. So, and Parthoda was witnessing my surgery in the OT. So, I'm sorry that we could not, directly show that surgery. That was a straightforward macular hole surgery. I should not use the straightforward macular hole surgery. It was a large macular hole of near about 600 micron size. So normally above 400 is standard classification that is a large macular hole. And but in Indian classification we do it little on Indian standard is little on the higher side. So whatever we get below 400 number of surgeries is very, very less. Now, I would like to show you something because Dr. Moria was showing the innovation for this. So, I would like to show you the innovation in macular hole surgery. So, what does it? Now, as a standard macular hole surgery, what we do is usually after doing complete vitrectomy, you peel the ILM, ILM peeling, and it depends upon the size of the hole. We do, have a calculation of that. The larger the hole, we do the peeling of the larger size of the peeling. So yes, that is the standard macular hole surgery and it gets closure. Now, after that, we realized that if we do a inverse flap technique, which was my technique today. So what you do is you do a ILM peeling on the other side and leave a central part of the ILM surrounding the hole. And then after the surgery, you peel that ILM and don't peel it off. You peel and then inverse it, put it in a multi-layer into the hole. You just plug it over there. You don't tuck it. You just put it multi-layer over there. So what does it cause actually? This layer actually acts as a scaffold and the glial tissue forms over there and it causes closure of the macular hole. So it has been seen that in below 200 size of the macular hole, whatever you do, it gets closed. So the credit goes to surgeon. 200 to 400, there is a debatable role of the inverse flap technique or by standard complete ILM peeling. So almost both of them are equal. But yes, if it is more than 400, definite role of inverse flap technique that closes it. Closure rate is much, much higher with inverse flap technique. So that's why I was putting that caption that inverse flap technique causes macular hole, and in Indian scenario definitely we do get much more larger size of the hole. Now ये सब चीज़ हम लोग कर लिए हैं, मैकुलर होल भी हो गया है, उसके बाद भी मैकुलर होल बंद नहीं हुआ है, failed macular hole. So what do you do in those kind of cases? So when there is so Ramakrishna Dev, there is a kahavat in Bengali, joto mot toto pot. That means whenever there is no different way of treating it, you do the multiple way of treating it, whoever wants in that way. So let's see about the retinal autograft. This is my close to the heart, and Parthoda knows about these things. So when we started these things, he was one of the first witness of these surgeries. So when you have, I'll just show you the standard ILM peeling. So this is kind of ILM what you peel it off as an inverse flap. I'll just show you just a glimpse of it. You can see that central area is little bluish, so that all those flap over actually into the hole. Now suppose this is a situation when you have a failed macular hole and you have a large size of macular hole, and you can see this is the peeled ILM size here. This is the ILM peeled area. This is the ILM peeled area, and the hole is remaining here. So what to do now? So the standard till now the standard technique is that you again restain and then take up ILM flap over there, free ILM flap, and then you put the plug over there. So what happens, it sometimes it acts like a macular hole to closing together, but here it is actually not working exactly the way of inverse flap. It is actually causing the fibrosis of that area. That's how the hole gets closed. Now, that's what I was telling, whenever there is multiple, so internal limiting membrane plug and gas for the endotamponade for the recurrent or the persistent macular hole. So this has been described very well. Next is, so the similar way of macular hole for the, there are different literature what I am just showing to you. Now a modified foveal and advancement technique. Now what it was, like Parthuda was telling today, when I was just putting the ILM flap into the hole, so it was looking like I was just scraping the ILM, even the retina, so that there was in this kind of failed macular hole, suppose this is a hole, and you just scrape the macula a little bit of a massage the macula a little bit of, so that it becomes little closure, and at the end of the surgery it becomes really smaller, and if you give them a prone position they get closed. So this is also has been described in failed macular hole technique. There are description of the lens capsule, the posterior capsule, nothing is there, so they just cut the posterior capsule and then implanted it over there. So that also acts as a fibrosis. Even human choriotic amniotic membrane, that has been described to put over there and causes closure of the macular hole. So this is just an example I'm showing. This is a pre failed macular hole, and this is after amniotic membrane. This was showing a kind of a scarring here, but yes, macular hole gets closed. But think of a basic concept of that. Either lens capsule or ILM or amniotic membrane, they are not the neural tissue. So it cannot, whatever, even if it is closes, it cannot create a neural tissue there. It is very, even a common man can understand this. So if we analyze these cases, so what I did is I just analyze my cases with HD. So this is after those ILM free flap I have grafted there, and saw this is the surrounding area is actually the retinal tissue, and this is central area is actually a scar. So it actually reduces the scotoma, but it does not cause next level of neural regeneration. So what I thought of after this, then I have designed a kind of a, why not, so any corneal surgeon is here? So it is actually other than Samudra, sorry, and got influenced from the corneal surgeon, that even if the corneal surgeon can transplant the retina, why transplant the cornea, why we can't transplant the retina? So this was the first case in India when I did it in 2014. So I have designed a kind of a retinal trifine, and then in failed macular hole cases, the main idea was there is to put the neural tissue per se there instead of putting the other tissues which is causing fibrosis. Now see what happens there. So this is a kind of around 475 was the size of the macular hole. So 550 trifine I have taken, little bit like 0.5 corneal size also we do take. So here also little 15 to 20% I do increase with the trifine size. And then I'll show you the surgery next. Yeah, so this is, I'm going to show you the surgery. This is very simple in a post-vitrectomized case. You go inside with this trifine. This is, I'm going to trifine the retina with the predetermined trifine size, which I have of 100 micron size of different size, and then rest of the part which was the tag was there, I just cut it with the scissor, and then in the left hand I'll just stop it here, pause it. You can see it very clearly that very well defined graft is here, and held it in my left hand. Sorry. Yes, so you just lift it with the left hand, and then this trephination is being done under saline, and then you put it there into the whole area, and then with the soft tip, this cannula, we just tuck it into the whole area, and then rest of the residual fluid you just take it out. Donor area, you laser, and then put gas. So now see what happens in the postoperative area. This is the failed case of macular hole, where the standard ILM peeling was done earlier, and then you put it with the graft, and you can see it. This is the graft tissue is very well taken, and which has some way normal configuration of the retinal tissues. Now, this is the hole is anatomically closed. Whether it is functioning, now the next question comes. Yes, that also we have proven by doing multifocal ERG of these cases. So I'll just show you how does it occur. So this is a case of multifocal ERG in a normal retina. There's no macular pathology, and you see this is a normal spike over there. Then the next one is a standard ILM peeling where there was no failed macular hole. This is a ILM peeling was done, and this was closed. This is a failed macular hole which has been closed by ILM replugging, and this is the graft case where you can see the spike is there. You can see over one page. This is a normal size, normal ILM, normal cases. This is a classic ILM peeling. This is the repeeling with plugging, and this is the macular grafting cases. So you can see there was significant amount of the spike. So this is one proof you have with the multifocal ERG, and I will show you another proof that this is a patient. This patient is having. I'm sure you are not able to read it from here, but this is I did it of central 10-2, and you see it here. The central ILM, this size. This was the foveal threshold was almost like 25 to 29 decibel. So which is, I think, all glaucoma surgeons they will accept that this is a significant amount of the macular threshold. So I will give you another proof that this graft is actually surviving. So what happens? This is the OCT angiography, and the fluorescein angiography has been done, and you can see there is a significant vascularization of the graft, and the graft is very well taken and surviving there. So this was of different cases. This was almost like more than 2,000 size of the macular hole which has been closed by this graft. So you can have the multiple choices, but you need to choose the right one, and that's how you can close it down. So
how you titrate? Means it was 2000 microns. So
no. Yeah, the 2000. So always usually graft shrinkage initial. I did it first case in 2014. So first case I failed because I did not calculate the graft shrinkage size. So I have put initially the same size of graft. So that's why the graft was shrunk, and it was actually has migrated under the retina.
So you need some extra.
So 20%. So that's what if you have a 500. Suppose the 500 size is your failed hole size. So you take a trefine of 600. And so I have a series of the trefine starting from 400 to as of now 1200 size.
So thickness retina varies in different populations. So how you do with that?
Thickness we are not bothered about.
Right.
Thickness, because you are doing on the autologous retinal transplant, you are taking from the same eye.
Okay.
Yeah, you are taking from the same eye. Yes, there was a common question that the rod and cone the percentage and the concentration is much lower compared to a fovea and the peripheral retina. I do agree, but you cannot get one more fovea into the other area. But yes, the retinal tissue, they have some amount of the rods and cones. So more you go to the periphery, this concentration definitely goes down. The preferred site, what I have decided, is in the just above the superior arcade, where the chance of getting good amount of the rods and cones is relatively high.
Thank you so very much, and congratulations.
No, exactly not. That's what the other, all over the world, those who are doing this retinal transplant in the other part of the world, they do cauterization of the size and then they cut it with the scissor. Now you see the difference between this technique and other. Here I want actually the neural tissue. Once the neural tissue, they come into the contact with the one neural tissue, the other, the aberrant regeneration takes place. The same way, like when you take a sural nerve and when you have the corneal desensitization or the trauma, then you transplant the sural nerve into the infraorbital foramen. And then there are evidences that corneal sensation improves much more. So here also the concept is, if you put a cut tissue of neural tissue into another raw margin of the neural tissue, then there is aberrant regeneration takes place. But if you cauterize those margin, then you are into the dead tissue. So that is the difference between rest of the world actually does the other way of doing it, except I do it with this Trifine, which is actually getting more popular over a period of time. So a lot of other international surgeons, they have also borrowed this Trifine as of now. Yes.
And you said less than 400 micron macular hole. Both the ILM flap and reverse ILM flap both give equally good results?
Almost, sir.
Almost.
Less than 200 is definitely, there is no
Same.
difference. But 200 to 400, there are doubtful, the literature reports are there. And even we do see that whatever, both the technique are equally effective, but more than 400, definitely inverse flap is much, have the closure rate is higher.
And what about the other tissues which have been used, like you mentioned, the anterior capsular flap and amniotic membrane? Do they have similar kind of contrast sensitivity and the quality of vision?
No. Sir, what I was talking, my first comment was, that was about the primary surgery. And this is what I'm talking about when you have a failed hole. You have done the surgery, but when you have a failed macular hole and then you use this graft, retinal tissue graft per se into that area.
Is the color vision in these patients affected? If we do, like say, patient has a macular hole in one eye, and if we do the color vision, is it affected or
Yes.
is it normal?
So you are talking about
No,
the standard.
natural. No. Supposing a person has macular hole, is his color vision affected?
Along in presence of hole or after the closure of the hole?
No, before.
In presence of the hole?
Yes.
Definitely.
Then after you have closed it, say a failed graft or a normal, or this one where you are saying it's a regeneration of the neural tissue, does it become better?
Yes.
It does?
Color vision is better, and the surgery what I have shown, this lady fortunately or unfortunately had bilateral macular hole, and I operated. Bilateral cases have failed, and I have done bilateral retinal transplant, and this lady is now reading newspaper.
So we are assuming that like the HeLa cells, which are the basic cells, and they grow into any cell that you transplant them, then that means that the rods or the cones are growing or transforming, because you've taken the retina not from the cone dense area, you've
Yes.
taken it from the rods dense area.
Yes.
So is there some way we can test how many cones have grown or how many rods are there?
No.
Actually, I think the ERG is a very good tool by which you can actually see the functionality. So apart from the anatomical success, which is shown in different ways, the functionality, the ERG is the best tool to show the ERG. And what he is saying about the
Here probably the microperimetry would have been the better way of demonstrating the because I don't have the access to that, so that's why I did central 10-2, and which has shown that around 29-27 of the decibel, which is an indirect proof or the substitute of microperimetry to prove it.
So, sir, after your surgery, can we implant premium IOL?
Definitely.
So
I would love to have those series of cases and then like to publish it.
Yes, we can collaborate.
only autofocus.
No, I implant, I think all the lenses available.
So let me just tell you, 2014 when Rupa came upon this idea, I was a part of the observer who was, observing meticulous the thought processes, enunciating every detail, refine, and as a researcher, you do understand that how many refines you would have rejected, how many times you would have said no to a particular technique, and ultimately landed upon. So it is with such a lot of perseverance and dogged determination, with his volume of clinical practice, which is so huge, yet he found time for this research and came up with this fantastic idea. Actually, you know, it's a fantastic innovation and he's proved it. So I think Rupak deserves us.
Thank you, Partha, for your kind words. Thank you so much. Yeah. Yeah. So this is I was expecting the two questions कि when you cut the retina, choroid cut नहीं होता है. So that was the next question I was expecting. I think there was other forum everywhere. I do expect this question कि आप retina काटते हो, trephine करते हो, that below is choroid, and choroid is the highly vascular structure. So once you trephine it off, don't you touch the choroid and there is no bleeding? No. So that's what like Partha was telling. So initial trephine was there, but the later generation of trephine, which I have put, there are two barrels as there inside. So actually there was a catch after 350 microns. So even if you press it also, it will not go and touch the choroid. So that is one issue. And second thing is that actually the fill of retina and the choroid is little different. So it is like if you have a lychee, put it over cake and then cut it. So the lychee and cake both are soft, but the configuration and the toughness of both of them are different. So it is difficult. If you have a very sharp knife, you can only cut the lychee, not the cake. So I'm just giving a crude example of how to do it. And yes, this has not this is a barrel, fixed barrel. So one size of the of your scleral entry, you need to enlarge it one size. Sorry. No, the size of the the trephine is longer enough to take care of the myopic eyes as well. Sclera? No, that's what, like, it's the autograft. I am not taking from the other eye. It's the same eye, from there I am taking it out. Choroid you are talking about? No, it does not make much difference about it. No, actually it does not cut. Sorry. No. Definitely it is not like a normal person. But yes, it has been improved from the preoperative to the postoperative area. Sorry, which? See, the patient are, most of the time the patient other eye is normal, so they don't complain of the color vision per se for the daily work. But otherwise also all the color vision has been suppressed for both red, green and blue.
They can see so the color they see.
Yeah, they do appreciate the colors. Yes, they do appreciate the color. Especially the primary colors they do appreciate. There are difference between the shades, but primary colors they do appreciate very well. Sorry, Akshay. I'm taking a lot of time. Yes. Correct. So it is a very valid question. Now, most of the cases, if you are talking about a failed hole, which has been done by the inverse flap technique, you cannot use it because there is already the fibrosis is there. But most of the cases, that's what I'm telling you, inverse flap technique, the chance of fail is much lower. But if it fails, most of the cases, inverse flap fails when the flap, goes off. The cause of inverse flap failing is you have put the inverse flap, but the flap has dislodged from there. So that's why it has not closed. So majority of the flap, the open hole or the failed or recurrent macular hole, you do not see any frill of those ILM surrounding it. So most of the cases it's a raw. Sorry.
Thank you, sir. Thank you very much. I think we should invite our next speaker, Dr. Narendra. So we'll take 1 more minute for the video to come. Yes.
Sir, what is your precautionary measures when you do the ICL in the calculation purpose, sir? Please focus on this.
Number one, you have to do a proper refraction. You have to be very careful. So for LASIK purposes, for these refractive surgery purposes, we do many kinds of refraction. Dry and wet and eye tracy refraction. When you do eye tracy refraction, it gives you the finding of constricted people, mid-dilated people, different. They give you different sizes: 3 mm, 4 mm, 5 mm. If this people size is there, it gives you different refractive error. So you calculate all this conclusion that the refractive error of the patient, and then you do the biometry. So if you take all these precautions, you hit the target, and you get.
So you follow some online formula?
Sir?
Or AI based? Do you follow any online formula or AI based, like newer formulas are coming up?
No, so we don't follow that. Lekin sir, in retina surgery, whatever you say, whatever you do, there are a lot of difficult surgery. It looks very nice, but then the improvement of vision is not there. Even in the macular hole surgeries, if you, if the patient's vision is less than 6/60, at the max probably it will be 6/60, 6/36. So we do not expect a very good vision, but we always counsel the patient that, look, your vision is slightly better, and it will not become worse. This is what we do. I don't know what you research. Any comment on that?
Comment on this? No, actually, there is significant transition from those earlier days to this now, and we do see a lot of 6/6 or 6/9 vision after macular hole surgery. ERM though on a routine we get 6/9 vision. There is no doubt about it. For macular hole surgery, it also depends upon the size of the macular, the duration of the macular hole, definitely. But if it is up to 400 and the operative vision, if it is less than 6/18, or the better than 6/18, so the outcome comes usually 6/12, 6/9, and near vision is N6, N8. So there is a significant improvement of vision, and the usable vision, what I am trying to say, that is a significant usable vision after macular hole surgery.
But the only problem is the patient, they do not report to you if the vision is 6/9. जब तक कि vision बहुत कम नहीं होता, they don't come to you. So that's the whole problem. If the vision is less than 6/60, you cannot expect the vision to improve drastically to let's say 6/9 or 6/6.
That's true. That's true.
Yeah. So if the patient comes early, you find the hole. Probably ILM peeling is fine enough, and the patient's vision improves. Everything is good. And congratulations to your such innovations, Dr. Rupak. Very nice. Pride of our nation.
It depends upon how you are convinced. So if you are convinced that the patient is symptomatic, if the patient is asymptomatic, patients depends upon 3-4 factors. How you are confident. Number 2, patient symptoms and patient's requirement and the patient demand also. if the patient is other eye 6/6 and 6 vision, this eye is 6/9 vision, and the patient is not, doing a kind of a very precision work, you can always leave up, have a close follow-up. I have a patient who is having a bilateral macular hole, 6/9 vision. I am following them up for last more than 6 years, and that lady is still remaining the same condition. So yes, it has to be decided from the case-to-case basis, but again, usually 6/12 is a cutoff point from where you decide about the surgery. 6/9, I'll still prefer of waiting for some time. 3 months, at least of 3 months.
Copy करें. May I request Dr. Rajendra Prasad sir to please come.
First order, maybe next order. ये नहीं ये फर्स्ट ये ये तो ज्योमेट्रिक लास्ट So, good afternoon. So today I am really thankful to Jharkhand Ophthalmic Society for inviting me here, and especially Dr. Kashyap, and Mrs. Dr. Kashyap for giving me this opportunity to operate some of the cases and present in front of you. This is a deferred, as you all know, that is a deferred right surgery. We have done the surgery and now we are showing the surgery here. So it's not exactly the live surgery what we have been doing earlier. Now because of the constraint put by the NMC, so we are doing the deferred live surgery. So we operate in the OT and then now we are showing. This is the real-time surgery what we are going to show you. So this is the case, as you can see, is a very soft cataract, and you know that soft cataracts are also as difficult as we find difficulty in operating very hard cataract. So never take easy the soft cataract, because many of these complications what we have seen, the PC rupture, subluxation, the lens going out, capsular axis. So all these problems, they happen with the soft cataract also. And it happens very frequently with the soft cataract. Because the reason too is like we take easy with the soft cataract, and at the same time soft cataract, operating soft cataract is not easy. It's real difficult. So this is the case I'm going to show you. As you can see here, some microscope setting is being done, because the machine which I have used is the Centurion from Alcon, which I have used first time today. So, because I've never used this machine in my life till now, because I've been using all other machines, but not the Centurion I've not used. And secondly, the microscope, a very good microscope, but it had a lot of attachment of resight and this and that, so many things. So for a cataract surgeon, it becomes a little difficult to operate on a microscope where there is a lot of attachments are there. eye becomes very heavy, your handling becomes difficult. So as you can see here, I'm trying to do the setting of the microscope as well as the machine. And the parameters of the machines are also very important, because I was trying to change the parameters during the surgery, because I do not know how this machine is going to act with my original parameters. So as you can see here, this machine is working at the IOP of 65, aspiration which I am using is 23, vacuum is 120, because this is the epinucleus mode. So most of the soft cataract surgery I do under the epinucleus mode. I don't use too much of phaco, because you don't need to use phaco. So you don't have to go to the phaco chop or phaco pieces and all these things you don't need, because you just use the good setting of the epinucleus mode and you can finish off the soft cataract. So as you can see here, now the very good glow, a soft cataract or some amount of the posterior subcapsular cataract. We still have to start waiting for the sister's order to start the case. Yeah. So I hope this computer also will be difficult for me to use, because we have been using Apple now throughout. Fast forwarding is really difficult. चलो ठीक है, अभी चलने देते हैं. So I'm using MBR knife for the side pot, and because I'm sitting on the top, so my incision is going to be at almost at 90 degree, because this patient had a steeper axis at the 90 degree, and I normally do all my cases in the topical anesthesia. I never use blocks, and I have not used any block for the last 20 years. So for the last 20 years I must have operated more than 1 lakh cases, but I have done all my cases under topical only. And I have started using now the phenocane, which is very, very good tool when you are doing under topical anesthesia, because phenocane gives you a very good some amount of the anesthesia insight in the intracameral anesthesia, and patient's cooperation becomes still better if you happen to use too much of turbulation in the anterior chamber. So the patient becomes quite comfortable if you use phenocane. And you all must be knowing the phenocane, like it contains phenylephrine, tropicamide and lignocaine in it. So it gives you a dilatation of the pupil also. Your pupil is constantly dilated and you get some amount of the anesthesia also. So this is the after the side port. I'm trying to, I don't know how to fast forward it here. So Arvind, you'll have to help me to fast forward. This is the capsular axis. So this is the capsular axis is being initiated. I use normally forceps only, because the second important point, I never use needle. I use only forceps, because if you command on forceps, you will never miss the capsular axis. Because capsular axis, good capsular axis, you can only make with the forceps. And the forceps has a much better control on the all the forces, that is the forces which we need to do the capsular axis. It gives a much better command. And the size, the circularity and everything can be commanded very well with the forceps only. And this is the specially made forceps, because I have designed this forceps which has a little longer flanges and very sharp tip. So you can very easily hold these edges. And as you can see, because the edges of the flap has to be folded on the capsule. Never hold the unfolded flap. So that is another important point, because always hold folded flap. And I have done the hydrodissection, because hydrodissection, another very important point in soft cataract is the hydrodissection. If you do a good hydrodissection, most of the problems of the soft cataract is solved. but your hydrodissection has to be good. And then second important point is you must do the hydrodelineation, what I'm doing here, hydrodelineation, to delineate your nuclear complex of the epinucleus and the cortex. If you are able to separate the nucleus from the cortex and the epinucleus, then handling of that soft cataract becomes very easy, because as you can see here now, because I have done a good hydrodelineation with the viscoelastic. And many times you can, if you do a good visco injection at the equator of the nucleus, you can separate the nucleus from the posterior capsule also. So even the bed of the nucleus becomes good. And the second important point is this is the rotation. You have to free the nucleus. So without freeing the nucleus, never start the soft cataract surgery. Because if you are not able to free the nucleus, you are not able to rotate, don't start. Make sure that you rotate it, whatever you do before you start the phaco probe inside. So do a good rotation, and once you are sure that your nucleus is free in the capsular bag, then you can start the surgery. And for this surgery, because the phaco probe which I am going to use here is Kelman tip. It's a bent tip, which again I never use, and because all the other machines, because especially the Johnson & Johnson and AMO machine, they all give you a straight tip, because the physics of these tips and this tip is absolutely different, because this work on the torsional forces and that works on the longitudinal forces. So this is the, as you can see, this is the bent tip, and again, as you can see, the tip is around 45 degrees. I do not know, like Dr. Bulla, what tip you use for the soft cataract. So this is the 45-degree tip.
I use 30-degree tip. I use Kelman tip. And
Kelman tip and 30-degree.
Yeah, 30-degree Kelman tip.
So as you can see, because this is the 45-degree, and which is not good for the soft cataract again, because you don't get the hold with good hold with the 45-degree. This is a specially designed splitter. As you can see, this is my splitter, which I am going to use to split the nucleus. In soft cataract, very, very important point is you have to split the nucleus into two. If you are able to split the nucleus into two, you can play it with it. If you are not able to split, then what will happen? You will try to hold the nucleus, and you'll keep on eating some amount of the nuclear part, and finally you will end up with a ball, and then ball changes into a plate. And if you land up with the plate, then you will be so difficult to remove that plate out of the capsular bag. So here I'm just trying, because as you can see, because I'm trying to hold the nucleus, but I'm eating up. I'm not getting the hold, because this tip is not good for me, but still I'm trying to split it. So as you can see, because I have been, yes, now you can see here, I have split the nucleus. Now this soft nucleus is split into two. Now if you are split, you can further split, you can split into 4 pieces also, if possible, but may not be possible, because the nucleus is very soft, and the tip which I am using is the 45-degree tip. And as you can see here, because I am still trying to split, and yes, now this again I have got a split. I'm not chopping, this is not a chop, this is a split. So you have to be sure that you're not chopping the nucleus. Don't use the sharp choppers for the soft cataract. Sharp choppers will never work. Rather, sharp choppers will hit the posterior capsule, and you will land up with the problem with the posterior capsular rupture and all. So you have to split the nucleus with certain amount of forces, and very special phaco parameter. You have to keep your vacuum low. You have to keep the almost 5 or 10 phaco power. Don't use phaco power at all. And you just need to have a little bit of vacuum to hold the nucleus, and you can split. Now once you split, then you have to use the second instrument also, because the second instrument, as you can see, because I'm trying to use more of second instrument now instead of phaco probe, because the second instrument is the one which is going to dislodge these pieces out of the capsular bag and bring it on the phaco tip. And if you are able to bring these pieces on the phaco tip, as you can see here, and then you can very easily phaco aspirate. So I'm not using any phaco power, it's just the phaco aspiration, very minimal power, hardly 5 or 10 power I'm using, and just the aspiration, phaco aspiration. And you can see very easily you can remove these pieces. And because they were split, they were free, they were away from the capsular bag, so you can bring them on the phaco probe easily, and you can aspirate them and complete. Now you are just left with the little amount of the epinucleus, and and the cortex. I normally use, in 100% of the cases, I use my bimanual irrigation and aspiration cannula, because this is the best thing to do. See, actually, a lot of people using coaxial, but the coaxial has certain limitations, which we do not have with the bimanual. Bimanual gives you much better control, because you can move on right, left, up, down, anywhere. And your irrigation is continuous and you can put the irrigation where you want. And it acts as a second instrument, because many times you can see the epinucleus becomes a little thicker plate, because soft and thick plate in these soft nucleus, soft cataract. You can go underneath the epinucleus and bring it up to the aspiration cannula. And the aspiration port and the irrigation port, you can interchange also whenever you want, because if you are not able to aspirate subincisionally or at any point where you are not able to hold it, you can change it and then go take it other way around and then start aspirating. So here, because I'm trying with the same area with the aspiration port, you can see, because this area is getting a little difficult now to aspirate. See, as you can see here, I'm trying, but because the aspiration cannula is under the incision at the point when I have entered, so I'm not able to hold it very well. And possibly I'll change it. See, I'm changing it. So I've changed the right and left hand, and this is the best thing to do, because you just change it and it becomes easy. Like you can go straight underneath the capsuloraxis margin to aspirate that epinucleus and the cortex. So like this. So you go underneath the capsuloraxis margin and then you can bring it out slowly. See, now it has come very easily. So this is the technique you have to change during the surgery, because every time you find some or other problem, you have to change your technique. That is the way to get a successful surgery done, because if you continue with the same technique, then you will end up with the complications, because you have to keep changing the technique. The lens which I'm going to use for this case is Vivinex. The Vivinex is the advanced monofocal IOL from the Hoya international company, because this is a Japanese company, and this is one of the best lenses I have used in my experience as a monofocal IOL. And as you see the injector system of this IOL, the injector system is so easy and so good. I think this is the best injector system we have now at present in the market. And it goes through 2 millimeter, 2.2 millimeter also, and you don't get any scratches on the lens or anything, because it's so smoothly it goes inside. And the tip is long, so you can inject the lens straight into the back. You don't have to inject away from at the incision, because you can straight go inside and inject, and it doesn't flip, like it goes very easily inside. And the material of this lens is so beautiful, like it's a glistening free. It don't give, very rarely you will find the posterior capsular opacification in this. See the tip, the length of the tip is so long. And the lens you can very easily inject into the capsular bag, straight into the bag. And it unfolds very swiftly, like it's not sudden, it doesn't unfold suddenly or doesn't unfold slowly also. It takes a beautiful time till you go inside to take your dialer, and by that time your lens is unfolded, and then you can put the lens into the bag easily. So this is how you can see, as you have seen, because this lens has landed up beautifully in the bag. And another important point in any lens, because especially in the soft cataract, is the removal of the viscoelastic is very important, because don't leave any viscoelastic behind the lens. You must remove the good viscoelastic out of the bag. And before we start the viscoelastic removal, what normally I do, I seal the main wound. So this is one practice I do. I have not seen many people doing this, because this is very good. Like you seal the main incision and then go through the bimanual, through the side port with the bimanual. And now once your wound is sealed, see, it becomes easy. Like you will not get the fluctuation in the anterior chamber, and you can go behind the IOL, in front of the IOL, to remove the viscoelastic easily. And this is how you completely remove the viscoelastic and complete the surgery. So I normally use intracameral injection also, like I think 99% of the people use. Dr. Partha, your comment on the intracameral injection? also दिखा दो उनका एक उनका क्या केयर ग्रुप ट्राई फॉर So, any question about the soft cataract? Anyone?
The deferred live surgery session is going
Right.
fantastic, and a lot of PG students have gathered. So you were all, they were looking for you. Everybody was asking, especially Dr. Arvind Maurya, and he had come with 10 autofocus pro lenses, which you missed because you all were not here. So it was grabbed very fast, and there were a lot of choppers and also. And right now we have 4 gift from Hoya. तो आप लोग बता सकेंगे कौन पीजी स्टूडेंट ज़्यादा पार्टिसिपेट किया है? मेरे पास 4 गिफ्ट है. अरविंद मौर्य आप किधर हैं? बताइए. 4 पीजी स्टूडेंट्स खड़े होइए. सारे पीजी, सारा पीजी लोग खड़े होइए. अरे हाँ, शुरू से ये दोनों. चलो तुम लोग दोनों बाहर आओ. और कौन? 2 और पीजी बताइए. कौन 2 पीजी और लाओ चाहोगे गिफ्ट? ये दोनों कश्यप का पीजी है. पार्शियलिटी हम नहीं कर रहे हैं. पार्थ विश्वास सर, प्रेसिडेंट इलेक्ट हैज नॉमिनेटेड यू. और 2 पीजी कौन है? हाँ ना 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 ना, मेरा कुछ नहीं है. अच्छा ये बताओ कौन पीजी बताए, चुनो भाई उसमें से 2 लाओ. हट, मलय सर थोड़ी पीजी लाओ. चलो चलो तुम लोग दोनों पकड़ो, दोनों एक ही पकड़ो. हो गया? पीजी को चुनो भाई. कौन पीजी कुछ सवाल जवाब दिया है? मीत, मीत वाज इन ओटी. तो चलो आप. कौन पीजी? कौन पीजी? तो जवाब कौन कौन दिया है? ओ नहीं, बदमाश. हाँ चलो मीत, वो ओटी में बहुत काम किया है. आओ लाओ जल्दी दो. कौन बताओ? कौन बताओ? आओ. कौन? अरे वो लोग कहाँ का बच्चा लोग? ये तो मेरे ही रैपिंग का घरेलू मामला. आओ छोड़ दो तुम. चलो उधर उधर पकड़ो पकड़ो. चलो लाओ दूसरा वाला लाओ. और है बेटा. चलो हाँ चलो फोटो खींचो. So we are privileged that the President of All India Ophthalmological Society has graced this occasion, and he has flew down for a few hours just to felicitate the foot soldiers who have worked to make the society win for 2 consecutive years. But before that, we will felicitate our 3 guest faculties also who are going from here. But first of all, we will invite our JHOS executives to felicitate our AIOS president, who is the chief guest of today's session. Sir, आइए please. JHOS executives, विभूति भूषण, president. Sir, president अब खुद आइए. Dr. BP Kashyap, Dr. Rajmohan, Dr. Nandita, madam. चलिए. Dr. Rashi. सब चलो सब बनाओ. चलो ना लाओ. प्रेसिडेंट लाओ. हाँ. प्रेसिडेंट जो सुंदर बसा. four boys. Second ready रखो. Akshay Nair. ये भी करो भैया. उड़ाओ. Okay. So please clap. We are honored to have you here. Now I request our chief guest, Dr. Samar Basak sir, to felicitate Dr. Rupa Kanti Viswas. He is the senior VR surgeon and director in Netralayam, Kolkata. He is the first surgeon to perform retina transplant surgery in India and the first surgeon to perform ROP surgeries in Kolkata. He performed more than 10,000 complicated retinal surgeries and recipient of Rees Buckler Award from ASRS, Best Film Award from URetina, and FIFA Award from AIOS, Best Innovation Award, and multiple awards for Best Video and KP Roy Award. So please sir, Joss, President-elect आप ही आ जाइए ना. Please, the photographer is there. Sir, chief guest, हाँ madam. Dr. Akshay Gopinathan Nair. He is working in the Agarwal Group of Eye Hospital, Mumbai, India. He is an expert in oculoplasty and ocular oncology and facial aesthetic. He has published 140 peer-reviewed Medline, PubMed Index papers, 20 book chapters, and 40 plus journals, served as reviewers. Because sir, आज इन्हीं लोगों के लिए उड़ के आए. जी मैडम खाना दीजिए. Dr. Sahiba Sethi. Dr. Sahiba Sethi is cataract and glaucoma surgeon in Arunoday Eye Hospital in Gurgaon, Haryana. लोग कहते हैं वर्दी डॉटर ऑफ वर्दी मदर, तो शी इज वर्दी डॉटर इन लॉ ऑफ वर्दी मदर इन लॉ. Held various workshops and performed in live surgeries, mixed surgeries across the country, runs mixed surgical fellowships to train ophthalmologists in the art of mix. So all the glaucoma people who are here, they can learn mix from her. हाँ. So you all are receiving award together jointly with the president and the president-elect. आ जाइए president-elect. So can we have a photo of all the 4 guest faculties? Akshay Nair. Sumit तो रह रहा है ना? He is going to Hazaribagh. You come with your. And Akshay Nair, 4 are going. अपना लेके आओ. हम लोगों को AIOS में प्रेसिडेंट एंड प्रेसिडेंट इलेक्ट दोनों मिलकर के नहीं दिए थे. बीच में जाओ. सर इधर आ जाइए. इन चारों को बीच में रखना है. And all the other one, 1, 2, 3. हाँ सर तो जा रहा है तो सर हो गया. Yeah, it's okay. It's okay. हाँ, yes. अरे मौर्या तो है ना, वो तो यू आर गोइंग देयर. So now we welcome our other guest faculties who have operated today. Dr. Rajendra Prasad, please फूलों से स्वागत करें. Flower only. अरे they are going to हजारीबाग. लेके आइए. तोड़ ताड़ दिया ये लोग. और दीजिए फूल. Dr. Bhalla, Dr. J.S. Bhalla, our he is very dynamic past secretary of DOS का बॉस. डॉक्टर अरविंद मौर्य प्लीज. 2 बार सही. डॉक्टर पार्था विश्वास प्रेसिडेंट इलेक्ट ऑफ फ्लावर. 2 फ्लावर आपको मिलेगा. चलिए आइए. तुम्हारा दिन बन गया. अभी फोटो सबको दिखाना घर में. Now, this is the time of JOS Excellence Award. First, we will invite the institutions who have played a big role for our Best Society Award for PG teaching, excellent PG teaching and the wet lab. So, Rio Rims, Dr. Deepak Lakra and Dr. Rahul Prasad. Rio Rims, first Dr. Deepak Lakra, President. उसके बाद है फ्लावर. चलो कोई. Dr. Rahul Prasad. These both, the duo has worked very hard and for the PG teaching, and they have shared photos also. Please come. Next is Bokaro General Hospital, Dr. Sophia Ahmed. She is a very, very hard working lady and she keeps very quiet but never go with her very quiet nature. She is extremely active teacher. Please clap for Dr. Sophia Ahmed. So CCL, Dr. Smita Anand and Dr. Tanisha Ojha, CCL Raj E. They have also done excellent PG teaching program and they have shared also the pictures, because once you share and you don't know share the pictures, we will hardly know. थोड़ा सा नाम में गड़बड़ हुआ है, तो मीन्स तनिषा इज द जूनियर एंड स्मिता इज द सीनियर, so don't worry, हम सब इसको ठीक कर देंगे. So they have done wonderful job and there is an appreciation from the president and the president elect. अरे रखो सब जाओ भाई. अरे प्रेसिडेंट इलेक्ट तुम लोग समझ रहे हो, बहुत बड़ी बात है कि नहीं राजेंद्र सिंह? And Kashyap Memorial Eye Hospital, Dr. BP Kashyap, please come. By under your leadership only it has happened, so please come. So they have in Kashyap Memorial Eye Hospital also we have 5 DNBs and they work very hard. Yes, sir. इसको उड़ा दो ना. क्योंकि वो खुश रहे. And there are societies who have also worked very hard. The Jamshedpur Ophthalmological Society is led by Dr. Rajan Verma and Dr. Ajay Gupta. Jamshedpur, please come, Dr. Ajay Gupta. Dr. Nandita madam. They have done lot of CMEs, madam. It inspires the shoulders, and once everybody is inspired, then only the goal is achieved. So now the turn is Dhanbad Ophthalmological Society. Dhanbad Ophthalmological Society. So I think Rajnikant Sinha sir, please come. He's our vice president, and he used to be organizing secretary of lot of Jharkhand ophthalmological conferences, annual conferences. Please come. He is representing Dhanbad. आइए विनय जी आइए. आइए ना चिरकुंडा. विनय जी आइए please. अरे you are representing your society. Now we invite Dr. Rashi Shyam. She is the one who has worked very hard for PG teaching. The journal part will be covered in the inauguration. Where is Dr. Rashi Shyam? Yes. She has not only done tremendous PG teaching program activities, she has done a big role for journal also, that you people will be, all the journal people will be felicitated there in inauguration. Here is the PG teaching. Yes, madam. Jaldi jaldi kariye. Dr. Pinky Pal. She is a highly active young lady and does lot of charitable work. She is in government sector and Jhaus के बैनर पे इसने बहुत काम किया है, especially the public awareness. Dr. Pritish Pranoy. Dr. Pritish Pranoy is a high volume cataract surgeon and he works in the government sector and he has also done lot of public awareness programs. So we are highly fortunate that the president and president-elect has honored all of you who has contributed for Jhaus achieving the Best Society Award for 2 consecutive years, and we hope that in Sir's tenure also there will be a hat trick. There will be a hat trick. Amen. Tali. Amen bolo. Amen. यही होगा. And उसके बाद 4 trick होगा. पार्थ विश्वास के टेन्योर में. I think all the felicitation part is covered. Now Dr. Rajendra Prasad, we have organized a birthday cake cutting ceremony also, because Dr. Kashyap informed me that today is his birthday and he has left his family and has come here. I didn't know. Morning 4 hours back my husband said ki please arrange a cake because today is his birthday. And now we can proceed with your talk. And I think we should finish and come upstairs for lunch. So only Saiba said his talk is left, I think. Sahiba. अरे हाँ हाँ. So Rashi has worked very hard for the journal, and this time physical form has come out, and last time our journal was in a CD, and that was also could not get published. So as the president is here, Partho, I will not invite you for this because it is formally launched in the inauguration function. So please आप लोग दोनों जाइए. जर्नल में कौन कौन इन्वॉल्व है? मलय, मलय, गो. सर को दीजिए. सर विल शो. मलय जाओ. They have really worked hard. The leader of this journal thing is Dr. Deepak Lakhda, but the lady behind did wonders, and the lady behind is Dr. Rashi Shyam. So big clap for her. बहुत अच्छा राशि, बहुत अच्छा. अच्छा किया सर, रख लीजिए. I think he should continue with his talk. I think I have not left any steps. सब हो गया. So I am really thankful to you. He had also some family issue. His parents' anniversary is there, so he has to go. हम parent-in-law is parenting. हाँ हाँ. General Bhatwa. अच्छा, people who are not going to go to Hazaribagh, please raise your hand. आप लोग जर्नल ले लीजिए. जनरल बटवा दे दो. जनरल बटवा राशि. अरे जो हजारीबाग नहीं जा रहा, डर के मारे हाथ ही नहीं उठा रहा है. डर के मारे, बिकॉज हम तो गुस्सा करेंगे. हाँ हाँ, वो तो उसको बेचारा का तो पेनाल्टी लग गया. पीजी एक भी सब चुप बैठा है. बिकॉज गेस्ट फैकल्टी रजिस्ट्रेशन का पैसा दे दिया है ना. तो जो हजारीबाग, मैडम आप लोग का रजिस्ट्रेशन हो चुका है ना? आप रजिस्ट्रेशन करा लिए ना? हाँ, सब लोग का हो गया है. बस पीजी लोग सब अब क्या किया जाए. दे दो सबको जनरल. अच्छा ठीक है सर, आप प्लीज कंटिन्यू करिए बिकॉज वी हैव टू गो, वी हैव टू टेक लंच. अक्षय चला गया ना? डॉक्टर मलय वर्मा, मलय अक्षय को लेके खाना खिला देते हैं.
Okay. So I'll be showing this second case of 20 years male patient. It's a traumatic cataract because the patient has had a trauma 6 months ago. He was hit with a rod on the forehead, and probably it was but although he's not giving any history, but it was hit on the eye also, so he developed this cataract. So the challenges were a lot with this cataract actually, because Dr. Bharti Kashyap said like you operate this traumatic cataract in live surgery. I said don't give me traumatic cataract in the live surgery, because you never know, these traumatic cataracts can behave differently during the surgery, because you never know like whether the capsular bag is intact or not intact. That is the first thing. The second is,
this is the fortunately or unfortunately,
oh, acha. Right.
Because those people by 5 o'clock हो गया. 5 o'clock तो भी टाइम है ना? कितना टाइम हुआ है?
अभी 3 भी नहीं बजा.
3 भी नहीं बजा तो डॉक्टर साहिबा और डॉक्टर इसका ही तो लोग पढ़ती है ना. आप कराइए, बिकॉज इतना ही तो सुनना है ना. छोड़िए कुछ नहीं है, बोलिए.
फास्ट कर देते हैं. ज़्यादा फास्ट नहीं. तो so as you can see, this cataract is totally white cataract, and as I was telling, like the challenges with the traumatic cataract is because of the presence of posterior capsular rupture, subluxation, vitreous loss, and so many problems can happen during the surgery. Because on examination I saw this patient that there was a capsular anterior capsular fibrosis, but I could not see any subluxation, and because you cannot visualize the posterior capsule in this situation even with the slit lamp, because nothing was visible behind this. So we carried out the surgery. But the very, very important point in such case is like you have to presume, even from the beginning of the surgery, you have to presume that there is a posterior capsular rupture. So that is the most important thing when you are operating any traumatic cataract, which you have not seen. You are seeing it after 6 months or 8 months or 10 months. And this kind of cataract then. This patient also had a pterygium also. So his steep axis was a little different, and this patient was posted for the one of the best lens available now, trifocal, that is geometric. This is again from the Hoya International from Japan, and the geometric lens, you all know that geometric is a trifocal lens, and this is absolutely different from the trifocal lens we are using these days, because this is recently introduced, not more than 5-6 months only. And I have used plenty of these lenses by now, almost 100-150 lenses I have used, and the results are fantastic. Because the prime point, what is the important point with the trifocal lens is the light loss. So when you are putting a trifocal lens in the eye, the trifocal means the light which is going inside the eye is going to be distributed for the 3 distances, for the far, for intermediate and the near. So if you have 100 light, so it's going to be 30, almost 30 for each. So your light which is used for the distance near and intermediate hardly remains 30-35% only. So if you have a less light for a particular distance, your contrast is going to be down. So your contrast is definitely going to be down, because you know you are not going to see as clear the distance, as clear the near, or as clear the intermediate object. So this problem has been tried by hundreds of companies to solve this problem, how to increase the light for the particular distance. The Zeiss, Johnson & Johnson's, and so many other companies, Trinova, so many trifocals came, but none of them could do anything. The Hoya has done a beautiful thing to take care of this problem. What they have done, they have made 2 lenses. One is called as a geometric and one is called as a geometric plus. So the light distribution in 2 lenses are absolutely different. What they have done, in one lens, the light for the distance is almost 60%. And other lens, the light for the near is almost 50%. So if you have a 60% light with one eye, and you put the other lens, because this is a combination of the lens, because you have to put one plus in one eye and geometric in other eye, then only you'll get the light gain. And if you put these 2 lenses in different eyes, your distance vision, you get almost 70% of the light. For the intermediate, you get almost 50%, and for the near, you get almost 40%. So this is what they have done by making the technology, changing the technology. So you just try, because I have tried so many lenses, and patients are really happy with this geometric lenses from the Hoya International. So this is the surgery. I'll just show you. I'll show you the light, the implantation in the light, because the surgery is important. So what I'm trying to put the first side port just away from the pterygium. Although this is the flatter axis. The pterygium area is the flatter axis of the patient, but the axis flat and steep axis is not much different. So I had the privilege to put the incision according to the pterygium only. So this is first, and as you can see, the lens is totally mature white, so the capsular axis is going to be a problem in this case. So I'm trying to stain under the air bubble, because always inject the air bubble first and then put the blue Rex, whichever stain you use normally, because then you have to inject the stain, and wait for a minute at least, half minute to 1 minute, because don't just flush it out, because let it stain the capsule. And once, now you can see that the capsule is well stained, and you can remove the stain with the visco, injecting the visco, because now the visco, normally use a visco dispersive in this situation, because visco will ask the high that visco will not work, because when you are staining this. See the visco cannula, I don't know, because you all must be finding, but many times the visco, some of the company, the cannula what they give is a sharp cut. If you try to enter from the side port, you are not able to enter. So I was trying to find out, like, give me a little thinner visco cannula, give me a little thinner visco cannula. But the available was that thicker one. And what I've seen is the Upper Swami is making beautiful visco cannula. Viscoelastic is also very good from Upper Swami, because this is from the care group. But Upper Swami's visco cannula, you just see it. It's round. It's not a cut. So any type of the side port you can very easily enter. So this is having a sharp cut, so you are not able to enter. So this is the main port I'm making at I think around 120 degrees. At 120, because I'm sitting on the top here also. I'll just show you the capsular access to be done in this situation. So, because I have published a beautiful technique that is called a saving needle, although I'm not using saving needle because I didn't find this is too much of intumescent. In intumescent cataract, there are a lot of techniques being used to start the capsular access, because one of the technique which I have published and I have devised is called as a saving needle microcapsulotomy. There you have to use a microcapsulotom to puncture the capsule, so that once you puncture, you are able to decompress the bag, because the fluid comes out, your bag is decompressed, your anterior capsule becomes soft and flexible, then you can start the capsular access. So here in this particular case, although it's a white cataract, it's not an intumescent fully, it's just a fluffy material was there inside. So I'm going to start with the capsular access forceps only, but still you have to be very careful doing the capsular access in this situation. And you just give a nick, short nick, and then hold the flap. So try to be a little smaller in the beginning, because don't go for the larger rexes in these cataract, because these cataracts are generally very soft. So you don't need very big rexes as we do in a very hard cataract. And keep injecting viscoelastic in between, because as you can see, again I'm using forceps only, because in these cases the needle is not successful. You can't use needle in because the flexible and soft cataract, because not exactly the firm cataract, because the very soft cataract you won't be able to do the rexes with the needle again. So keep injecting viscoelastic in between, because keep, as I said, keep the flap folded. See, the flap has to be folded. Never start the capsular access with unfolded flap. If you do with the unfolded flap, your capsular access is going to extend to the periphery. Keep always folded and hold the edge when it is folded. Don't hold the edge if it is unfolded. So make sure, because this is very important trick in making a capsular access in this situation. In otherwise also, but here it's very important. So keep holding the flap when it is folded, and your vector forces should act in a way so that your the centrifugal and centripetal forces are balanced. So neither of these two forces should overcome each other. If centrifugal forces overcome, your axis is will go to the periphery. Now this axis is trying to go to the periphery, but I have increased the centripetal force, so I brought it inside. And as you can see, because I brought it in, and the axis is complete. So doing rexes in these white cataracts, especially if it is a fluffy and little bit of intumescent, the rexes becomes very important, because if you are able to do a good rexes, then the rest of the surgery is very easy, because the cataract is very soft. Now another important point, because after doing the rexes, I will be just trying to do a little bit of hydro, because don't do a vigorous hydro, because you do not know that the posterior capsule is intact or not. If you do a vigorous hydro, you are going to rupture the posterior capsule and everything is going to go into the vitreous. So don't do vigorous hydro. You don't need hydro, because if you are very confident, then you can do a very minimal hydro to see that what kind of cataract you are dealing with actually. Now here in this particular case, the patient was not very cooperative. His lids are turning in. He had a very bad eyelash, as you can see, because we have put, as you can see, we have put this sheet 3 times. The sister changed the sheet, but still you see the eyelashes are poking inside, and we have cut some of the eyelashes. Still see some of the eyelashes are going inside. So it was so difficult to manage this particular patient, because he was not cooperating at all, and secondly his eyelashes were troubling us so much. lids were scooched, his eyeball is sunk, and everything, all the possible problems are there with this particular patient. And now, as you can see, because I'm trying to do a bit of very little fluid injecting, but then I saw that this cataract is absolutely different. It's not like a traumatic cataract what we normally see. So what I decided, because you have to change your technique, as I said, every moment you have to change your technique seeing the case. So after doing this, I decided I'll not use the phaco in this particular case. So what I did not use phaco. I just went with the irrigation and aspiration cannula inside. So you can see here, and trying to, with the visco, I'm just trying to see the material. I was trying to see the posterior status of the posterior capsule, but most of the central portion was stuck to the posterior capsule. You can see here that most of the central portion is stuck to the posterior capsule. So you have to, if you used phaco probe in this situation, you are definitely going to hit the posterior capsule, because this is stuck to the traumatic cataract. It's stuck. Although the capsule may not be ruptured, but it's stuck on the posterior capsule. And if you use phaco probe, you are going to draw the posterior capsule also. So don't use. So be sure, like, you have to dislodge it first from the posterior capsule. So don't try to do chopping or any other technique, because I'm just going inside with the irrigation and aspiration cannula inside, and then you see the surgery, how it went. Because I could remove everything with the irrigation and aspiration cannula only, because I never needed to use the phaco probe. So this, at this point, as you can see now, so first I went to the main port, because I do not want to put too much of pressure. I just want to confirm, because when I'm switching on the irrigation, the pressure is going to build up in the anterior chamber. So if you have a posterior capsular rupture, it's going to burst. So I just went through the main port to make sure that it's not ruptured. So at this stage, I was sure that the capsule is not ruptured. So capsule is intact, but now to remove this material with the help of the irrigation aspiration cannula, you can see here, because I'm just using the irrigation and aspiration cannula. It's very simple and very safe to remove this cataract. And slowly and slowly, but it may take little longer, because phaco is a very fast technique. You can remove everything, but then in this situation, using phaco would be serious and may lead to complications, because I just use the irrigation and aspiration cannula, and slowly you can aspirate everything. And I'll just show you the little later part of this. Now you see the material which is coming very easily on the aspiration cannula. And I'm using the irrigation cannula, the second instrument. See, actually in phaco surgery or any surgery, especially in the cataract surgery, your second instrument is very important. The person who knows how to use the second instrument is going to have the successful surgery. It's not only your main port or main device, it's the second device which is very important. So you have to choose your second device, your chopper or anything, like you have to choose this very well. Make sure like you're bringing the good, using the good chopper. So there are hundreds of choppers. If you go to the market, you just ask for the chopper, he will show you 100. So you get confused what to do, which chopper you should take. And there are so many people there with their name, so many choppers. This is the best, this is the best. Everyone will say this is the best. But take your decision, which is the best. So you can see here now, because most of the material I have taken out with the irrigation cannula itself, and so this is how the removal of the cataract is complete with the irrigation without taking any risk. So you are risk free, and surgery is complete. Now I'm doing the polishing now of the posterior capsule, because since it was intact, and these cataract, because do a good posterior capsular polishing, because in children especially the posterior capsule is going to get fibrous or opacified later on. If you do a good polishing, then you may not land up with that problem also. And so because the polishing can be done with your irrigation cannula also, or with the aspiration. The aspiration cannula is always sandblasted. It's a little rough, so you can dislodge them, and then with the irrigation cannula you can just wash it out and aspirate it. So this is how the removal of the surgery, the removal of the cataract is complete, and everything is seems to be okay, and I'll just show you the lens now. So this is the lens. As you can see, this is the injector system of the lens, and you all must have seen this injector, because this is one of the best injector, and this is the same injector which we use for the Vivinex and even for the geometric also. And this is a yellow lens, and it's a blue filtering lens actually, because the blue color of the light is filtered out. This is how the lens looks, because this is the plunger, and it goes inside, and you can see the lens goes very easily inside. Now during the implantation, as you can see, the pupil constricted during the implantation, so I had to put the lens on the iris. So what I was telling was like the pupil constricted, so I didn't go into the bag straight. I just kept the lens on the iris, and then after seeing the situation, then where is the video now? अच्छा जल्दी चला गया. Okay, so this is the implantation of this lens is complete, and you see the eyelashes, but surgery was completed successfully. So thank you very much, and I'll stop here. It was uncooperative, not because of this, but it was structurally uncooperative. These structures were different. Thank you. So any question you want to ask? See, actually, because I'll tell you two important things, because as you have seen, like in phaco surgery, because it's the patient's cooperation, you need only up to the making incision. Once your instrument goes inside, once your chopper and the phaco probe or two cannulas goes inside, you don't need any cooperation from the patient. That is Rexis, yeah, definitely. But see, actually, because when I saw this patient outside, he was looking quite convenient kind of patient. But I think it was not exactly his cooperation, it's the structure, because he had a little sunk eyes. His lids were not very good, and had a pterygium. But still, like we could complete the surgery successfully, and the blocks, actually the important point with the blocks, because what I find is, if you give a block, the total physiology of the eye changes. The parameters or the control what you want, actually, because in your hand it goes to the patient's eye, then you lose the control, because you never know that how this eye is going to behave, because once you give the block. So that is why, because I stopped using block at all, and any kind of case, like whatever is the cooperation, whatever type of cooperation, I don't give any block and complete with the topical only. Thank you.
We have our last video session. It is on MIGS, and though it is a short surgery, I think it requires a great lot of skill. So we have Dr. Sahiban Sethi from Delhi, and she will be taking up from here.
Thank you so much, Dr. Rashi, and I'm really thankful to Jharkhand Ophthalmic Society for inviting me here. So today what we're going to witness over here is something unique. It's called minimally invasive glaucoma surgery. Now, up until now, the only surgeries that we were familiar about in glaucoma were trabs and tubes. And these, as much as we may deny, are invasive surgeries, and not everyone, not all glaucoma patients need it. So now with the advent of minimally invasive glaucoma surgery, which has been around for, let's say, not longer than 3 to 4 years, we have an option which is completely new, completely bleb free. It doesn't carry as many complication rates as trabs and tubes do. And there is also an option of intervening early on in the disease process. So even your ocular hypertensives, uncontrolled, even your mild to moderate glaucomas, all of these patients can benefit from MIGS. Now comes the question, if we are happy, if we have been happy for the past 50, 60 years just doing trabs and tubes for our glaucoma patients, why learn MIGS in the first place? So the answer to this would be that, for 50 years we've been redirecting aqueous to the subconjunctival space, when we know that in primary open angle glaucoma the problem lies in the level of the trabecular meshwork, right? So because of the obstruction of the trabecular meshwork, there is hindrance of aqueous outflow and increase in eye pressure. So what MIGS does is that it targets this obstructed or defective trabecular meshwork, so that there is a direct access of the aqueous from the anterior chamber into the Schlemm's canal, thus restoring the natural physiological outflow of aqueous. So now let's give a very short profile of this patient. This patient is a 50-year-old patient, one-eyed, and he is phakic. He's got a clear lens, so cataract extraction wasn't necessary. But he had allergies to his anti-glaucoma medications, and he had a mild glaucoma. So now when I say mild glaucoma, I mean mean deviation less than 6 decibels on visual fields. So in such a case, doing a one-eyed patient with a mild glaucoma, he's got just allergy to anti-glaucoma medications, but he's controlled on anti-glaucoma medications. Would you justify doing a trab in this patient? So ideally not. Now that we have this new technique, why not save him from the high complication rate, high failure rate of trabs and tubes that carry along with them? So preoperatively, this patient has received pilocarpine to constrict the pupil, because we are going to be working in the angle area, and we want the phakic eye to not be, the lens to not be damaged. So initially the patient is lying coaxial. And over here the surgeon is sitting temporally, and I'm making a 2.2 clear corneal incision. So now this incision is different from a phaco incision from the fact that it's completely clear corneal, maybe about 1 mm interior to the limbus, contrary to our phaco incisions, which are perilimbal incisions. Now a high molecular weight sodium hyaluronate, 1.8% is being injected. You can see how viscous it is. It is almost semi-solid, so it doesn't flow out. Now the reason why we use sodium hyaluronate is because it's a space forming cohesive viscoelastic, and we want the angle to completely open up. We want the anterior chamber to be good and deep, so that we can work and move our instruments in the angle, which is a very small area, and we are working under very, very high magnification. So one needs to have a good space, one needs to have good hand stability. And right now what's actually going on is positioning of the patient for the mixed procedure. So you'll see maximum of the time is taken for this, because the positioning is also different. Now we have been comfortable so far only working with coaxial microscopes. With MIGS, how it is different is that the microscope is inclined 35 to 45 degrees away from you, and the patient's head is also not completely supine. He is tilted, his neck 35 to 45 degrees away from you. So that is the kind of alignment that we need to have to be able to see the angle. Over here we are targeting the nasal angle, because that is where the maximum number of collector channels are there. So by opening the nasal angle, we are hoping that the outflow is maximum. I've placed a little bit of sodium hyaluronate on the cornea as a coupling agent, And now we are going to be attempting to see the angle by placing the gonio prism on it. There are various types of gonio prisms that are available. The one that I'm using over here, no financial interest, is iPrism SX, because I feel it gives me the widest, sharpest view of the angle, and I'm able to maneuver and cover about 100 to 120 degrees of the angle nasally. I don't think the full video is here though. Okay, so I think I cannot stress enough how much a good visualization is of paramount importance for a mixed procedure, because once you have a good visualization, once you're familiar with your angle structures, the surgery is just 5 minutes and anyone can pick it up. So over here, Acha, do videos hai. Okay, so next laga lijiye. So when we put our gonio lens, what we want to see is an en-face view of the angle, which means that the trabecular meshwork, the Schlem's canal and the root of the iris should be facing us. They should be distinct 3 structures, and something very similar to this. So one can see over here with my cursor, I can point, this brown line is the trabecular meshwork. This is the scleral spur, which is a thin white line. I think the surgery is already started here. So what the procedure that I'm going to be doing over here is a Kahug dual blade excisional goniotomy, which means that I'm going to be stripping the trabecular meshwork in the nasal angle about 100 to 120 degrees, so that the problem or the obstruction that lies in the trabecular meshwork is completely taken out, and there is direct access of aqueous from the anterior chamber into the Schlem's canal. So that's the idea behind this. Now we have about 5 types of mixed procedures that are available to us in India. This is one of them. This is a Kahug dual blade. And what we are doing over here is going to one end of the nasal angle, piercing the trabecular meshwork, then flattening the blades so that the dual blades which are attached to the KDB glide over the trabecular meshwork and strip it in toto. A little bit of hyphema is a desirable end product, because this hyphema comes from reflux blood from the Schlem's canal, which is once the Schlem's canal is deroofed by removing the TM, the blood has to come forward. So that is a desirable sign. So this is basically the area that we are going to be stripping. Again, there are 3 techniques of doing it. Basically, we have to cover about 100 to 120 degrees. So you either go out to in, or you go in to out, or if a person is really right-handed, then they can just mark where their left end will be and go to the right extreme and then strip all the way to the right. That's a procedure called mark and meet. So over here I've done an inside-out technique, and at the end of the procedure, the trabecular meshwork strips are just hanging there. So there are 2 ways of removing them. They cannot be left because they can re-adhere and cause peripheral anterior synechiae. So these strips that you have excised have to be removed out of the anterior chamber also. They can be done by 2 methods. One is you either use a micro forceps, go grasp them and pick it out, which is what I did over here, or you can even aspirate it with your INA cannulas during viscoaspiration. So this is me, I think, attempting to remove them with an ILM forceps. So you can see the strip that I'm bringing out. This is a strip of the trabecular meshwork, and I'm going to be placing it over here to show. So that is the brown structure, which is the trabecular meshwork. It looks really tiny, but this is about 100, maybe 90 to 100 degrees of the Schlem's canal, which has been deroofed. So that's pretty much the end of the procedure. It is straightforward, but it does bring about a good reduction in intraocular pressure for those early glaucomas who don't need aggressive surgeries and can benefit from this. It also most likely are combined with cataract surgery, since this patient did not have any cataract and needed some sort of intervention. We've done this without a cataract surgery in this patient, but it is ideal for those cases who are already glaucoma patients, who are also developing cataract, need to undergo cataract surgery. So now just instead of doing a plain cataract surgery and continuing them on their anti-glaucoma medications post cataract surgeries, which also 45% of the times gets hiked up. So after a cataract surgery in a glaucoma patient, you end up giving them more medicines than they needed before the cataract surgery. So there is little bit of progression of glaucoma. So now if you combine the cataract with MIGS, you're able to not only just halt the need for anti-glaucoma medications, but also probably bring them down after surgery. So that was my time. Any questions? I'm open to this. I am running a MIGS program. I don't want to use this platform to tell the PGs, tell anyone who's interested in doing a MIGS training. I've been doing it in Gurgaon at my hospital, and it's a surgical hands-on training of about 10 cases. And believe me, it's not difficult to pick up, but yes, it does require an expert hand already. So thank you very much for having me here. Right. No, sir. I'm holding the lens with my left hand, and I'm only performing the procedure with the right hand. You do have prisms. There are various kind of prisms available. The one that I'm using is a disposable prism, which unofficially can be ETO'd and reused until you crack it. But there are also lenses which are very exorbitant that you don't need to either tilt or hold them. They're so it's like a biome which is attached to the microscope, and it just sits on the lens. So your left hand is free, but then again, what are you doing with your left hand if your left hand is free? In this procedure, you really don't need your left hand for anything else, so you might as well just buy a cheap lens and use it for that. Right. So like I said, this is not a coaxial microscope setting. It is when the microscope eyepiece is tilted away from you. So now for knowing whether how much tilt there is an app called Measure. It's available on iPhones and even Android. So what you're supposed to do is, suppose your microscope is tilted, you just place your phone and tilt it along with the microscope, and it gives you the angulation that you have tilted it. And generally, like in my hospital, because I do MIGS routinely, I've made a mark on the microscope itself. So every time I rotate, when the two marks meet, I know it is 35 degrees. So this application is actually required only once if you're a regular user. Yes, always. Because you need to have, see, the patient's head is tilted this way. So generally, if I have done topicals, but it's really, you struggle with it. Because when the patient's head is tilted, they also tend to think that they're supposed to look in the other direction. But eye has to be central and the head only has to be turned. So that's very difficult for them to understand. कि सीधा देखो तो उनको समझ नहीं आता सीधा क्या होता है, head ही अगर tilt किया हुआ है तो. That becomes a challenge. So yes, topical is not really recommended. So statistically speaking, with KDB, we expect about a 30 to 35% drop in IOP. It is, any form of MIGS is equitable to 2 anti-glaucoma medications effect in drop in IOP. But when you're counseling the patient, you're at least assuring them that 1 AGM will be taken off at the end of the surgery. But theoretically speaking, it can carry the load of bringing IOP down as much as 2 medications would. So again, so there are comparative studies. Comparative studies say that 100 is as good as 180, even 180 is as good as 360. We had a recent publication saying that 360 is better than 180. So a 360 degree cannulation and stripping is called GAT. The version of which we do in India is a suture GAT. We don't have expensive devices, but we have a 60 proline suture that you can cannulate into the Schlep TEMS canal and then just pull it out. Entire trabecular meshwork just gets stripped. That does, by experience, also bring down more IOP reduction, and it is recommended in more severe glaucomas. So in early glaucomas, you would probably want to still preserve the trabecular meshwork, because GAT, although the IOP reduction is more satisfying, it also has a little more complication rate. The hyphemas are more, it is more challenging to perform, pain in the patient, all of those problems are there a little more than that. Yes, ma'am. Yes. So my journey started with BANG. When she says BANG, it means bent ab internal needle goniotomy. This KDB blade is a sophisticated blade which the MRP for which is 55,000. So there is a cheaper version of this, which is a 27 gauge needle that you can just bend and do the same maneuver. Now the problem with BANG is that it doesn't have such a clean cut as this one is. That is more of a goniotomy. When I say goniotomy, it's basically just opening up the trabecular meshwork from somewhere in between. This is an in toto excision. That means it's carrying the entire strip and taking that entire thing out. So of course it's a cleaner cut, it's neater. The incidence of peripheral anterior synechiae post that is much less. With BANG also what happens is that when you have, like, okay, suppose this is your trabecular meshwork, you're cutting it through, these two leaflets also tend to fuse. So over time, now that we have about 3 years of follow-up, we feel that BANG patients don't do well in the long run. So KDB is a better bet. Absolutely. The Katina lenses, yes, no, I don't think so. That was just to encourage you to start the surgeries, but they cost about 1,500 and they are also reusable about 4 to 5 times, so it's pretty economical. The iPrism SX, that costs about 6,500. That is also reusable as many number of times as you feel the clarity is intact and also it doesn't crack.
Yeah, it is going to be about 4 o'clock and she has to leave for the airport also. So can we please discuss upstairs with lunch? Yeah?
Sure. Thank you very much.
Thank you, Dr. Sethi.